Okay. We are live. All right. Whew. All right. Good morning. Good morning. Good morning. How was your weekend? Good. Does anybody have any questions about what we've gone over so far? Any questions? You guys getting my wrap-up emails? Yeah? Okay. Those will be good for you for review. All right. So over the weekend, you had 2 chapters of homework. You had chapters 2 and 3. You read in the yellow book and then took the tests on page 182 and 183 of the white book. When I call your name, if you can let me know your scores or how many you missed. If you didn't get to it, no worries. Just say pass, and I'll come back to you at a later date. Okay. Those of you who are joining us remotely, I know about half the class looks like is probably joining remotely. When I call your name, just give me your scores or how many you missed in the chat, and that way I'll go through and update the grade sheet. Alexa, stop. We have to change your name. 195. Tanya. Kira. Thank you. Carolise. Naraya. Thank you. Christopher. Jada. Peyton. Alex. Jessica. Rebecca. Thank you. Amy. Thank you. Bernanda. Thank you. Stephanie. Thank you. Chayla. Thank you. David. Ariana. Thank you. Owen. Thank you. All right. Any questions on the ones that you missed? Anything that you need me to explain to you? Everybody good? Good. One of the things that you may have seen in chapter 2 that I want to go over really quickly with you is, good morning. Chapter 2 says that you have to have 75 hours of training. And if you added up the hours that were here, it's only 32. So, you know, what about those other hours? So Florida, good morning. Florida does not subscribe to that 75-hour minimum. So Florida is the only state that allows challengers. So you don't have to have any education, experience, training, nothing to be able to take the state exam as a challenger. So that may potentially impact your ability to transfer to another state. Some other states say, hold up, we know Florida doesn't require that 75 hours. So if you want to be a CNA here, you have to take our test. Or some states even say you need to go through our training too. So that's something you would want to know before you move to that state. So make sure you're doing your research. In your skills book on page, I don't remember what page it is. Oh yeah, go ahead. That's fine. In your skills book, the white book, page 1, I think it's 180, but let me look here. Nope, not 180. 172. 172 and 173. There are all of the boards of nursing for every state. So if you decided you wanted to move to New York, you would look up New York's information, contact them, and tell them, hey, I want to be a New York CNA. I'm one in Florida. What do I need to do? New York's pretty easy. They say, cool, do our background check, because background checks don't transfer. Do our background check, pay us a little fee, and we'll give you a certification in our state too. Okay. Not all will go that easy. You'd want to know that beforehand. All right, so let's do a quick review of what we learned last week. How do we know what to do with each patient? Care plan. It's not just the care plan, it's the whole care plan and nothing but the care plan. And while you're doing the tasks on the care plan, what should we also be doing? Observing. And who do we want to report those observations to? The nurse. Very good. This forms the foundation of everything that we're going to do from this point. So today we're going to go through 4 skills. One of them doesn't really count. It's blood pressure. You're not going to be tested on blood pressure, but still, every single skill, we always start with the care plan. So if somebody asks you to do something, your first thought is, what does the care plan say? Okay, good? Makes sense? So now that we know what to do, let's get into how to do it. Every skill starts with the opening. Every opening starts with a knock. Once you've knocked, you're going to enter the room, and what are we going to say to the patient? Yeah, we're going to greet them. Very good. And what else are we going to say to that patient? Okay, so first we want to do their name, okay, and then our name and what we're there to do. So I got a lot to say in the opening, lot to say. Once we've introduced ourselves and described the skill that we're going to do, what do we need to get from them? Permission. And for the exam, remember, you are going to be a patient. When you are a patient, the evaluator is going to give you a script to follow. You're going to be pleasant and cooperative, and you. Don't try to make this difficult on anybody. That's not your role here. Your role is to be the best possible patient you can be. Okay? So for the test, they will always say yes or of course. All right. Once we've gotten permission, we want to close the... Is that curtain clean? So what do we want to do after we close curtain? Wash our hands. Very good. After we've washed our hands, we can go get our supplies. Remember, clean supplies need clean hands. But our most important principle out of all of that, the most important thing that we want to remember more than anything else is don't touch the resident until your hands are clean. Very important. If you forget some of these other things, you might be okay. You forget this, you are not okay. Why is that? Pathogens. Why would we be concerned about pathogens? Okay, because their immune system is already busy. If you catch a pathogen, you'll probably be okay because you're healthy. This guy catches a pathogen and it could be lights out because their immune system is already busy. Do you guys understand why that is the most important principle? This is not just for the test, guys. This is in real life. That's when it really counts. It's really sad because direct care workers kill just as many people as surgeons every year. We just don't talk about it. I think we should be talking about it. Remember, we have the most contact with the patients. So generally speaking, if the patient catches something they didn't come in with, it's probably us. Statistically speaking, we have the most contact with the patients. And we're all up in all their holes. Right? Have to think about that. All right. So once we've done our opening and we've gotten permission and we went and got our supplies, we have to start thinking about gloves. And the question we're going to ask is, do I need gloves for this skill? Well, why don't you wear gloves for everything? Wouldn't that be easier? Just wear gloves for everything? Why can't you do that? Very good. So you stop paying attention to what you're touching and how that could potentially contaminate the patient. So by being very selective in our glove use, we're paying much more attention to those gloves. Remember, those gloves aren't just there to protect you. They're there to protect the patient as well. So we have to think about the rules that go along with gloves. So now there's a question. Okay, if I'm not wearing gloves for everything, now I got to figure out when I do need to wear gloves. So we have 3 rules we're going to go through. So the first question I'm going to ask myself is, when I'm doing this skill, is there a possibility I could touch body fluids? If the answer is yes, you need gloves. If the answer is maybe, you need gloves. If the answer is no, let's go to the next one. When doing the skill, is there a possibility I could touch non-intact skin? So wounds, rashes, sores, or incisions. If the answer is yes, you need some gloves. The answer is maybe, you need some gloves. If the answer is no, let's move on to the last question. Last question is it possible that I might touch personal skin while doing this skill? If the answer is yes, you need gloves. The answer is maybe, you need gloves. If the answer is no, you don't need gloves. And we can proceed by washing our hands before and washing our hands after. Give me 1 second. I just got a message I need to respond to. Okay, sorry. All right. So this goes along with our supplies. Okay, if we're going to be getting supplies, we have to think about the gloves that we're going to be using or not using. So this goes along with our supplies. So this is pretty, you can shortcut this. Am I going to be touching body fluids, personal skin, or non-intact skin? If the answer is yes or maybe, you need gloves. But if we decide to wear gloves, what's first thing they should touch? The patient, not the supplies, not the bed, not the curtain. Get everything ready and then put your gloves on. That keeps those gloves clean for the patient. Once you've used those gloves on the patient, though, they're soiled, and now we have to pay attention to what we're touching in the environment. Don't cross-contaminate. And then at the end of the skill, when we're all done, we need to remove those gloves the right way. We pinch up and pull off, and we go under and pull off. Good? Questions? Questions? All right. So make sure you're removing them correctly. We also have to think about a barrier if we're using supplies. A barrier is going to be put on the table. It's a clean place to put our clean supplies. Remember that table is not clean. And you can only touch your supplies with clean hands. So the barrier is all about clean. Clean, 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 clean. So when we get supplies, the first thing we're going to do is get a barrier. And it's got to be done first before you go get all of your supplies. Because if you get your barrier with your supplies, you're going to hold that barrier up against your uniform. And our uniform is not clean. So you've got to make sure you're doing this in the right way. So we get the barrier first, put it on the table, go get our clean supplies, and put those on the table. Easy peasy. All right. Sometimes we need a privacy blanket. We use a privacy blanket anytime that the okay. No, Alexis, we just got started. You're good. Anytime your patient is uncovered or undressed, we need a privacy blanket. This helps protect their privacy, but also keeps them warm, because remember, your perception of temperature is different from your patient's. We're going to talk about that in detail today. So we use a privacy blanket anytime the patient is uncovered or undressed. And we're going to put this on in a way that keeps our patient covered at all times. So we put the privacy blanket on over the sheet, pull the sheet down underneath, and that keeps our patient covered. At the end of the scale, we pull the sheet over the blanket and pull it out underneath. That way your patient is always covered. I don't want to just pull the sheet all the way down before I put the blanket on, because that exposes the patient. You always want the patient covered with something. Okay. We don't want to snap or shake that blanket. That releases pathogens right where we can breathe them in. And at the end of the skill, if we wear gloves for the skill, you want to remove your gloves before you take that privacy blanket away. That way you're not touching the sheet with body fluids. Remember, we wear gloves for body fluids. So you don't want to touch that sheet with the body fluids on your gloves. All right. Linen rules. Now, most of these are repeats from something we've already learned. Remember that linens cannot touch your uniform, and that you have to have clean hands to get your linens. You also know not to snap or shake them. We're going to get to the other two in a future lesson here. But let's go to the end, and this is a new one for us. Unused items must be discarded. Now, what does that mean? That means if you take too many of something and you don't use it, you can't leave it in the room until later. If you don't use it, it goes in dirty linen. You can't trust that something outside of your site is considered clean. Now, that's an important nursing principle. Those of you that go on for nursing, that's going to be super important. If it's out of your sight, it can't be considered clean. Okay. All right, we'll cover the rest of those linen rules in a later lesson. And then we have the closing. Now, the closing is done at the end of every single skill that we do. It's always the same, never really changes. You can say it in any way you want to say it. You just got to make sure everything is being addressed. So comfort, curtain, call light, clean and safe environment. So I have a routine that I use. Thank you very much, Ms. Jones. Is there anything else I can get for you while I'm here? Are you comfortable? Would you like a magazine? Your environment is clean, bed is safe. I can ask if they want the head of the bed adjusted. You don't have to, but that's kind of part of comfort. Here's your call light. I'm going to open the curtain and go wash my hands. If I need to document, I'll document after I wash my hands and then wash my hands again. So all of the points that are addressed in the closing is we have to make sure the environment is clean. The bed height is in the lowest position. That's that clean and safe. We want to ask about comfort. They need to hear that. We're going to address preferences. So if they say, yeah, I want the head of the bed down, let's do that, unless our care plan says otherwise. You know, that actually is a thing. I don't know if you guys know this. There's a medication that we give patients early in the morning, and the medication requires that they remain in an upright sitting position for at least an hour after taking the medication. So sometimes your patients don't know of that requirement, especially if the nurse is giving them the medicine. So they may be sitting up in a chair and you come in and they go, oh, my back hurts. Can you put me back to bed? Or, oh, I've got a headache. I want to go lay down. That care plan, you've always got to check the care plan, because that care plan may say must remain upright until 9 a.m. Okay. So even something as simple as head of the bed up or down might be reflected in the care plan if there's a special situation. Good? Makes sense? Okay. All right. Ensure the patient is covered. Open the privacy curtain. Give the patient their call light and instruction. Clean your hands. Document and wash your hands again. And remember, our most important principle here is don't touch, don't end the skill unless you have clean hands. Good? All right. So let's review pulse. We learned how to take a pulse. Do you guys remember this from Wednesday? A pulse is a measurement of how many times the heart beat over 1 minute. Now, you don't always have to count for 1 minute. We only count for 1 minute when the care plan tells us to. How else could we do this if we weren't counting for 1 minute? Okay, so 30 seconds multiplied by 2, or 15 and multiply by 4, right? So there's lots of options here. You could also use a pulse ox and get just a number. No multiplication necessary. How do we know which method to use for the exam? The care plan. So we're going to follow that care plan. Very good. While we're doing that, oh, thank you. Cool. While we're doing that, I think I'm getting thumbs up on YouTube. I think that's what when they show up here. While we're doing that, oops, let me go back here. While we're doing that, we want to make sure the arm is supported on the bed or table or somewhere. For the test, your patient will be laying in bed, so just make sure that elbow is on the bed. You can lift the forearm up like this while you're taking the pulse. You can lift the forearm up. That way you don't have to bend, but you can't. Yeah. But you can't lift the whole arm up. Okay. Good. She needs some surgery. All right. What is a normal pulse rate? 60 to 100. What do we do if we get under 60? Report it. What if we do if we get over 100? Yeah, easy. What area of our fingers do we want to use to take a pulse? The tips, not the flat area. Remember, the tips are important. Which finger do we use? Yeah, anything but the thumb. But ideally, the index and middle finger are probably your best bet. They have the greatest concentration of nerves at the fingertips because it'll help you feel. But don't use that thumb. Okay. All right. Where is a radial pulse located? Okay, at the wrist. Where at the wrist? Okay, on the thumb side. Is it way down here? No, it's at the, where the creases are, at the bendy part of the wrist. If you're down here, you're too low. That artery is buried very deep. You're not going to pick it up. Okay, so it's got to be at the bendy part of the wrist. All right, for the test, somebody else is going to be counting with us. Who is that? Yeah, the evaluators. They're going to be counting with us. So how do they know when we're going to start and stop? You got to say it out loud. So you're going to pick a starting point on the clock, and out loud, you're going to say start. And you're going to count in your head, not out loud. The evaluator is going to count in their head, not out loud. And at the end of that minute, you're going to say stop. Remember that you counted something. Having it in your head does nobody any good. So if you count something, what do you have to do? Document it. Yeah. If I ask you, see, the thing about healthcare is there's no busy work. There is no busy work. They don't give you stuff just to make you look busy. Everything that we ask you to do in healthcare, there's a reason that we ask you to do it. So if I'm asking you to take a pulse, that means that I need that information for something. I either need to give a medication, or I'm trying to evaluate the effectiveness of a medication, or I'm preparing a patient for a procedure or something. There's a reason I'm asking you to take the pulse. So if you take the pulse and it's up here in your brain, does that help me? No. So for this skill, actually for any documentation skill, if you forget to document, it is a fail. Because having it in your brain does not help me or the patient. Make sense? So if you count something, remember you have to document it. Forgetting to document is a really big deal for the test. I'm plugged into a lot of Facebook groups, and that's probably one of the biggest complaints about people that take the test. They'll get on there and they'll complain, that evaluator was too harsh on me. All I forgot to do was write it down. I don't understand why I failed. Okay, so yeah, you didn't follow the care plan. Care plan needs you to write it down. So understand that it's not about you. Let's think about the potential consequence to that patient if we don't write it down, because that's really what they're grading us on. What consequence did that patient have because we didn't write it down. Well, maybe they didn't get the medication they needed. Or maybe we missed a side effect that could have been picked up. Or maybe the patient wasn't cleared for a procedure. So forgetting to write it down has a huge impact on the patient. Good? Makes sense? That's really what they're grading you on, guys. Now, in Florida, we have 2 evaluators. So for the pulse, we're going to count twice. We also learned how to dress a resident with a weak arm. We want to ask about clothing preferences, and we want to get the clothing before we undress the patient. Now, that's really important. Why do we need to get the clothing before we undress the patient? Right, so they're not exposed. Yeah, imagine how vulnerable they feel. Now take their clothes away. They're laying down. This is a very vulnerable position. And especially if they're weak or ill, they may not have the ability to fight back. Can you imagine putting your entire safety in somebody else's hands and you don't know them? Can you imagine? I mean, what would you, if you were weak and injured or sick, laying in this bed, somebody takes your clothes from you, you are now naked in this bed, and then they start to abuse you, and you have no ability to fight back. Can you imagine how absolutely terrifying that would be? Now, patients understand that they're in a very vulnerable position. You do not have to point that out to them. Trust me, they know it. So we want to take steps to make sure that our patient feels secure when we're in there with them. And this is part of that. Make sense? So we always ask about clothing before we get it, and we always get the clothing before we undress the patient. We also put a privacy blanket on so that they're not truly naked for anybody.
Will that be on the test? Do we have to dress them during the test?
Yes, that is a tested skill.
Do we have to ask them for their preference?
Right. For the test, it's going to be on a mannequin, just like this. So you're going to have to dress the mannequin, and you're going to ask the mannequin, what do you want to wear today? Now, the mannequin is going to answer you, but it's the evaluator that actually answers. And there's going to be 2 outfits on the shelving unit. There's always 2. One of them is the outfit that's being described. The other one is a red herring. It's not, it's short sleeves and a different color pants. So they're checking, are you following the care plan? So remember, our care plan said long sleeve button or snap front shirt, right? So the other shirt that's going to be on there is a short sleeve pullover. So that's finding out, are you following the care plan? And the pants, they're going to say red pants, and there's also blue pants on there. So it's making sure that you're following the preferences. So each of these little steps, I mean, they seem like really small steps, right? They actually count big. Does that make sense? Okay. All right. So anytime we lift anything, we're going to lift from below with the flat palms supporting all joints as we move them. We're going to undress the strong arm first and dress the weak arm first. That way the garment just slides right off that weak arm without a lot of movement, and the new garment slides right up that weak arm without a lot of movement. Okay. We don't want to overextend or force movement. We're going to adjust that clothing for neatness and appearance. And we're going to make sure that we put all dirty items in the hamper and put the call light in the stronger hand. Good. Now remember, I've got these in flashcard form. So you guys can go back and watch this, this lesson. Remember, the replays are always on the website. So you can go back and watch this review, and we're going to have more reviews as we go. This isn't the last time you'll see this. We build on our reviews. But if you want flashcards of this, I have them in here. So you can review. All right. So we didn't do this one. We're going to skip that. So this is where we're at so far. We've learned skill rules. We've learned the opening. We've learned glove rules. We've learned about barrier, privacy blanket, and linen rules. And we've mastered the closing. So we still have 4 principles we still have to learn. And it's only class 3. So look how much you've learned so far. You just recited them to me. I know you know them. We have to learn how to apply them. But the first step is to learn them. Okay, good? Questions? All right, so go to page 116 in your skills book, and we're going to learn a new skill. Okay. All right, you guys ready to learn something new? This skill, I'm going to sit because it takes me a little while to teach you this one. And I'm going to demonstrate how this is set up for the test. Okay. So this skill is provide hand and nail care to the patient. So if you look down the side, you'll see all of the principles that are involved in this skill. So skill rules, opening, glove rules, barrier. We know all those. Linen rules. We know most of those. Washing rules, basin cleaning. Oh, those are new. And then the closing at the end, we know. So here they are all spelled out for us. If you follow all of these steps, you will guarantee to get 100% on the test. If you just do everything that's on each one of those banners, you will have 100% on the test. Up above, you'll see the short version of the skill, kind of the Cliff Notes version. I have a video for this. And along the bottom, you're going to see test-specific information. So they're giving somebody with your level of experience 11 minutes to do this skill. 11 minutes. Now we're going to get to the care plan in a minute so you can figure out what we need to do in that 11 minutes. But I'm going to shortcut this for you real quick. You are going to wash one of your patient's hands, clean under the nails, and file the rough edges and apply lotion. One hand. And they give you 11 minutes. That is way more time than you actually need. So don't rush this. Okay? That's when students usually make mistakes, is when they start to rush. Now, I know you're being tested. It's not comfortable. You want to get it done and get out. I get it. I understand. But when you rush, that's when you make mistakes. So slow yourself down just a little bit, especially for the test. Okay? This is going to be done on a testing student. They're going to be sitting in a chair. Charting is not required for this particular skill. But when you are this patient for this, remember, all of you will be patients. When you are the patient, the evaluator is going to set the scene. So let's say that you're a patient for this skill, and she's going to be performing it. You would be told to sit in a chair at an overbed table that they will already have set up near the bed. Something like this. Okay. The evaluator will set the scene for you. So I would be the patient for this. I'm sitting in a chair with an overbed table near the bed. This is how it would be set up. Good? Okay. All right. So everything with a check mark we already know. We just went over it. You proved you know it. So let's move on to the 2 we don't know. So we're going to learn washing rules and basin cleaning. Okay. Let's start with washing rules. Washing rules are going to be featured in 5 skills. 5 skills. This is on page 112. We have very specific rules. Just like we have very specific rules for skills, we have very specific rules for opening. We know when to use gloves. We have rules that govern barrier use and privacy blankets. Well, we have rules that govern washing. And this is one of the longest ones that we have. Now, this is in 5 skills. So we really do want to know how to do this because a big part of what we do is washing. So we're going to get into each one of these steps as we go. Remember that I do have a video for this. You can watch the video. I'm not going to show it to you, but you can watch it. And page 113 has the notes for what I'm about to explain to you. So again, you don't have to take notes. So when we wash anything, any body part, if we're going to wash a body part, we have to learn the rules around it. It's not just as simple as go wash something. There's some rules here that have to be followed. And I want you to think about how you bathe, okay? When you go jump in the shower, you don't even think about it anymore. You're on autopilot. You get wet, you put some soap on, you rinse off, you get your hair wet, you shampoo it, you rinse it out. Right? You have steps that you do that you don't even think about. Your mind is probably solving the world's problems when you're in the shower or singing your very best karaoke. You're not really thinking about what you're doing, right? So that's what makes this a little bit hard for you because you stopped paying attention to bathing a long time ago. So I have to go back and remind you of basics because when you're washing somebody else, it's really easy to forget a step. You would never dream about putting shampoo in your hair and then getting out without rinsing it. It wouldn't even cross your mind. You would always make sure you rinse the shampoo before you get out, right? But when we're washing somebody else, it's really easy to put soap on and then forget to rinse. Because it's not us. So we have to start thinking about how we're doing these skills on other people and where the pitfalls might be. Okay. So we bathe, we wet, we wash, we rinse, and we dry. Good? Make sense? So when we're cleaning somebody else, I want you to say in your head, whatever I wash, I rinse. Whatever I rinse, I dry. And this helps keep you on track. Okay. So when you're washing something with soap, in your mind, whatever I wash, I rinse. So now you know your next step is to rinse. Whatever I rinse, I dry. So now you know you're getting ready for the drying step. This keeps you on track. I know it sounds simple. I know you're thinking in your mind, well, of course I wouldn't forget to rinse. I mean, I'm not that boneheaded. I've got this. But I'm going to tell you during the test, if you don't do this, you will forget a step. You will. You're being stressed. So I need you to kind of work this in. Okay, good. All right. So since we need water for rinsing, we can't apply soap to the water in the basin. Because if we put water in a basin and we put soap in that water, we now no longer have soap or have clean water for rinsing. It's all soapy. Does that make sense? Now, some of you are going to be, yeah, but you can get another basin. Just get another basin and put water in it. Now you've got one for washing and one for rinsing. You can do that, but let me explain the pitfalls of it. There's always a cost. And in this case, it's an actual physical cost. How many of you guys have ever been to a hospital? How many of you got a bill? Oh, they're not free, are they? Hospitals are not free. They give bills. And in this county, this might surprise you. If you don't pay the bill, they take you to court. Yeah. One day every month at our courthouse is set aside for medical collections. So don't think you can skip out on that bill. They're going to get it from you one way or another. So we need to understand that medicine costs money. Now, the problem is they don't tell you how much medicine is going to cost when you're getting it. You have to wait until the very end and you're home, and then the bill comes in the mail. Nice, right? It's like going to a restaurant and you don't get to choose what you eat and you don't get to decide whether you can afford it. They just bring you what they want to serve you and give you a bill after. I wouldn't go back to that restaurant. So why does this matter? Well, CNAs perform the most bedside care, don't we? We also do all the ADLs, which is what takes supplies. Every single one of those supplies is going to be scanned out and charged to your patient. They're not free. So if you use an extra toothbrush every single day because you don't want to clean out that toothbrush, your patient is getting charged about $9 for each toothbrush every single day. You go get another basin, they're not free. They're about, I think somebody just had like a couple classes ago, just brought in an itemized bill. And I think the basin was like $28. I can go to the Dollar Tree and get one for $1.25. It's a lot of money. So we don't want to be using supplies if we don't have to use the supplies because your patient is going to get charged for them. Interestingly enough, though, one of the fastest growing segments of non-traditional nursing is bill review. This is amazing. These are RNs that you can contract. And let's say that you go to the hospital, you get a bill. Let's say it's $80,000. Not unreasonable, by the way. So you get this $80,000 bill and you're like, oh my gosh, I can't afford $80,000. So you contract with me. I don't do this, by the way. This is an illustration. You contract with me. I go through the bill and I go, nope, this wasn't necessary. Nope, this wasn't necessary. Nope, this wasn't necessary. And I dispute those unnecessary charges. Now, I'm an RN. I've worked in the setting. I know what's necessary and what's not. And we take that back to the hospital and we show them that all of these are unnecessary, have them take them off the bill, and I get a percentage of that. So ultimately, who did that cost money? Well, the patient got them written off. So who actually paid for those supplies? The hospital. Who pays your wages? Yeah. So if you're using supplies that are getting written off, the hospital still has to pay for those. They don't get them for free. They have to buy them. So what do you think is going to happen to your wages? You're not going to get pay increases. They're going to pay you less. You're not getting paid what you're worth. So talking about supplies is actually kind of an important topic. Do you guys see that? Because it will directly impact your wages. Because somebody's got to pay for those supplies. So using a second basin, not a good idea. It costs the patient money. No need for that. But if we go a step further, there's another reason that just grabbing another basin isn't a good idea. And that's because of the time it's going to take you to clean that second basin. Remember, we have to clean everything before we put it back. So now you're not just cleaning one, you're cleaning two. You do that over and over and over again, and there goes your break. You're right. So it's a lot of extra time. Now, let's talk about the environmental impact of that. Where do you think these basins go if the patient doesn't take them home? The landfill, that's right. So this is something we used for a very short amount of time, and now it ends up in a landfill somewhere. Probably not great for the environment. Does that make sense? Good. So we have to think about these things when we're learning to do these skills, because you're going to get out there in the real world in a clinical setting. And some CNA out there in the clinical setting is going to say, oh yeah, out here in the real world, we just use two basins. And I want you to have the ammunition that you need to understand why that may not be a good idea. Okay, good. All right, so the good news is we don't need 2 basins. One works just fine. We just don't add soap to the water. No soap in the water. Basins are no soap zones. So if we just keep that water clean, then we can use it for washing and we can use it for rinsing. And when we use it for washing, we're going to apply the washcloth or apply soap to the wet washcloth, not to the water. Okay, good. Questions? All right, so when we're getting that water, we have our basin in our hand. We go over to the sink. Now let's back up for a second and figure out what we've done up till this point. We've done our opening. Hi, Miss Jones. My name is Patty. I'm your CNA today. I'm here to do hand and nail care. Is that okay? Close curtain, and I went and washed my hands because I have to do that. And then I went and got my barrier, put it on the table, and I went and got my clean supplies and put them on the barrier. So far, I haven't touched anything unclean. Good? Questions? Okay, so I've got my clean my clean basin in my clean hands, and I got to go over and get water in that basin. Is that faucet clean? No. So what would I need to turn that water on? A paper towel. Now, this is non-negotiable because we know that faucet is the dirtiest thing in the bathroom. So if you're going to get water for bathing, you always have to use a paper towel to turn the faucet on. Always, always, always. Some people try to get around this by putting on a set of gloves to turn the water on. Do we need gloves for this? Gloves are way more expensive than paper towels. Okay. All right. So we're going to use a paper towel to turn the faucet on. And now, oh, this is going through. Yeah, your hands are clean. The faucet is dirty. So to keep your hands clean, use a barrier. Now that we've got the water running, we have to check to see what temperature it is. And we're going to use the inside of our wrist right in here. This is the most accurate water temperature gauge that you have. We don't make you pull out a thermometer and check it to see what the test isn't about that. You just want it warm, not hot, not cold, just warm. Different people have different preferences. I'm a hot water girl. I want it hot enough to take my skin off. I want it hot, hot, hot. Now, my husband is the opposite. He likes cool showers because he works outside. He doesn't like hot. He likes cool showers. You put me in a cool shower and I'm screaming. How many of you guys have a water preference? Everybody. Do you think that your water preference is exactly like the one of the person sitting next to you? So can you assume that your water preference is exactly what the patient wants? So this is an important checkpoint. We're going to check the water temperature. It should feel warm, not hot, not cold, just warm. And then we're going to ask our patient to check it. But let me explain why. This is a very important concept that you need to get. So we're going to ask our patient to check it. As we age, every part of our body goes through changes. Everything in the body goes through changes. And one of the biggest visual changes that you see, in addition to gray hair and wrinkles, is if you look at the hand and arm of an older person, you'll notice that you can see the veins. I mean, it's like they stick out. They're very, very visible. You guys ever seen that in an older person? Now, I'm getting there. Won't be too long, and I'll be able to use myself as an example here. But what that shows us is that everything changes with aging. So when we're young, we've got this big, juicy fat layer between our skin and our muscles. So when we're young and plump, right, that fat layer does a lot of different things. Number one, it protects us when we're children from bumps and bruises and when we fall and get in scrapes and stuff. It's a protective layer. But it does something else as well. It's a temperature regulating layer. The problem is that that layer of fat, as we age, goes away. It gets smaller in middle age. And as we get older, it pretty much just goes away in our extremities. So what does this fat layer do, and why should we care? So that's what we're going to get into here. I want you to think of that wet layer kind of like, or that fat layer kind of like a wetsuit. So think about a wetsuit for a second, right? When you're in the ocean is super cold. You put a wetsuit on to protect you from those outside temperatures. But it also keeps your body heat in. And that's because room temperature always wins, or your surrounding temperature always wins in this case. So let me explain what I mean by that. Let's say that you are baking a pie. Okay, you put a cherry pie together, you throw it in the oven, 325, it bakes, gets all nice and brown and bubbly, and you pull it out of the oven. When you pull that pie out of the oven, you would consider it hot. It just came out of the oven. It's hot. Does that pie stay hot? If you leave it on your stove, what happens to that pie? It cools down, and it will never go below room temperature. It gets to room temperature and stays. Everybody got that? Now, pie goes well with ice cream. So let's get a thing of vanilla ice cream out of the freezer. When we pull it out of the freezer, it is cold. It's frozen. So you put that ice cream on the counter. Does it stay cold? No. What happens? It warms up to room temperature. So room temperature always wins. This is a universal physics principle, cannot be broken. Room temperature always wins. Now I'm going somewhere with this, okay? Room temperature always wins. So what would you consider the room temperature in here to be, roughly? Roughly, give me a number. 75. 75 is a nice, easy number to work with. All right, so the room temperature in here is about 75. Anybody know what normal body temperature is?
96.
Almost.
98.
98.6, right? We use a range, 97.6 to 99.6. Let's just make it easy. I like easy numbers, right? So let's just say 98. What was room temperature?
75.
And room temperature always wins. So hold up. If the body is 98 degrees and room temperature is 75 degrees and room temperature always wins, there's got to be something more at play here. In order for your body to stay at 98 degrees, there has to be work being done, okay, by your body. So this is how critical this is, guys. If you drop below 95, you are in hypothermia. If you drop below 93, you are dead. Remember, room temperature always wins. Room temperature is about 75. So if you walked outside right now, what would you describe the temperature like out there? Hot. Yeah, and it's not even 90 yet. It will be today. It's going to be right around 98 degrees today. But right now it's around 90, and we would all consider that hot. Now remember, 93 is dead. So we aren't even at dead temperature yet. Okay? So we all know that 98 degrees is very hot. And room temperature always wins. So how does this work in the body? Well, this means that you have to have a mechanism of creating heat inside your body. That's why we eat. Have you ever heard the term burning calories? It's exactly what we're doing. we're using that food to create heat to keep our temperature at around 98 degrees. Does that make sense? That's a lot of work because room temperature always wins. That means your body's got to do this 24 hours a day. There is no time off for good behavior here. Your body has to burn calories to create heat 24 hours a day. Your body doesn't want to work that hard. It's kind of lazy. So we have this layer of fat that helps keep that body heat in. So our body doesn't have to work as hard. That layer of fat acts as an insulation layer. Good? So let's think about that for a second. If as we age, that insulation layer goes away, but we have to stay at a certain temperature above 95, that means that more calories in our elderly people are going to go toward creating heat. It's not going to be as efficient. So because more calories are going to creating heat, that means that they're probably not going to have as much energy. You ever seen an older person that says, "Oh, I'm tired"? Well, that's because their body is working hard to maintain that body temperature. So what a lot of older people do, they don't realize they're doing it, but they do this. They crank the heat up. You ever walked into grandma's house and you're like, "Oh my gosh, grandma, it is hot in here." And she's like, "Oh no, it's fine. It's perfect." That keeps her body from having to work as hard. She's not fighting so much against room temperature. Do you guys see that? But it also impacts that fat layer impacts how we perceive outside temperature because that fat layer is laying right on top of your nerves. You got nerves and blood vessels, fat layer, skin. Good? So if we don't have that fat layer, that means that everything felt by the nerves is going to be felt more intensely because there's no separation. So when we are using water, that water might feel fine to you, but you have a fat layer that the patient doesn't have. So when we're working with patients and we ask them to check the water temperature and they go, "Oh no, that's too cold," don't argue with them. Go warm it up. If they say, "Oh my, that's too hot," don't argue with them. Go cool it down. I've seen way too many CNAs argue with patients over this. "It is not too hot. I just checked it. It's fine." It's fine for you because you've got a fat layer that they don't have. Don't argue with them. Good? Make sense? This step is the most important step of all of our bathing skills. This one right here. Asking the patient to check the water temperature. If you don't do this, you fail. Is the test about you? Who's the test about? And that's why this step counts big. Good? Make sense? All right. So when we get water, we're going to use a paper towel to turn it on. We're going to check it with the inside of our wrist. It should feel warm, not hot, not cold, just warm. And then we're going to ask our patient to check it. How does this feel? Now for the test, the patient isn't the only one that's going to check it. The evaluator will stick their finger in that water to see if it's truly comfortable. So don't think you're going to get away with something here. Make sure it's truly comfortable. All right. So whatever we wash, we rinse. Whatever we rinse, we dry. We've been over that step already. We're going to get to this one that's grayed out a little bit later in the program. Okay. So we'll save that one for later. And rinsing is way more important than you think. This is what the skin looks like when we leave soap on it. It actually dries out the skin. When you dry out the skin, we could end up with cracks, which are body openings that let stuff in and out. So rinsing is way more important than you think it is for the health of the skin. It's also super itchy. It is super itchy. So be careful about that. Make sure that you're rinsing. We want to change the water if it gets cold or soapy. Remember, we got 11 minutes to do this. That's a long time, guys. 11 minutes? Yeah, that water might cool down, especially if it's not all that hot to begin with. So we've got to kind of pay attention to how long this is taking us and whether that water is still comfortable while we're in the skill. Change it out if it gets cold or soapy. Dry surfaces should remain dry. So if we're working at a table, like hand and nail care, I got a barrier on the table. Make sure the absorbent side is facing up, because if the water spills out, we want to make sure that it doesn't get onto the floor. If we're working with a patient in bed, like bed bath or pericare, we want to put something under the patient to protect the sheet. We don't want anything wet. So wring your washcloths out really, really well and pay attention to whether your surfaces are getting wet. Anytime we warm lotion or we use lotion, we warm it up first and then dry off the excess. Any lotion that you put on there's a saturation point of your cells. Your body can only absorb so much. Have you ever put lotion on and your hands still feel real greasy afterwards? Okay, that means that your skin has absorbed everything it can absorb. That's it. It's not taking in anymore. If you leave that lotion on the hand and they go to pick up a cup of hot coffee, what could happen? Yeah, absolutely. So an important safety step when we put lotion on is to warm it up first, put it on, and then dry off the excess. Take a towel and get that excess off so that they're not slippery. Okay. So those are all the washing rules. Now, washing rules go hand in hand with basin cleaning. Basin cleaning is anything that holds liquid that we use on a patient is going to have to be cleaned before we put it back. But it doesn't have to be sterile. CNAs always try to make this sterile. It's not. We're not steriling anything. It's just clean. So for the test, this is very simple. We're going to rinse it, we're going to dry it, and we're going to store it. No matter what we use for the test, whether it's a bath basin, an emesis basin, a graduate container, a bedpan, doesn't matter what it is. If we're using it for the test, we rinse it, we dry it, we put it away. That's it. But how we do that matters. I'm going to show you this skill in just a few minutes. You're going to see basin cleaning done in just a few minutes, and you're probably going to have some questions about it. I want you to remember that everything that I'm showing you is complying to the testing requirements. Rinse it, dry it, store it. But while we're doing that, we have to remember that we're doing it with dirty hands. So once we've rinsed that basin, we don't want to touch it with our dirty hands or our dirty gloves. We also don't want to touch the front of the drawer to put it away with dirty hands or dirty gloves. So what do you think we could use to keep our dirty hands or dirty gloves from touching the basin or the drawer? Paper towels. And that's what you're going to see in this process. Okay. Remember, it's not sterile. So basin cleaning is on page 90. You can see that this is going to be in a whole lot more skills. That half the skills that we learn will have some sort of basin cleaning. And our notes are on page 91. So the first thing we have to think about is, where would this normally go? If we are working with saliva, when you brush your teeth, do you brush your teeth over a sink or a toilet? Usually over a sink. So if we're dumping out saliva, where would it normally go? Where are we going to put it? Sink, absolutely. When we're bathing something, you can put that water in the sink, just like hand washing. Doesn't matter what we're bathing, that water can go in the sink. But if it's body waste, like urine or feces, where does that normally go? Yeah, please don't put that in the sink. Okay. So when we go to empty our basins, we just have to think, where would this normally go? And we put it there. Now, once we've emptied that basin, we're going to rinse it. I can touch the faucet now because I'm not going to touch the patient anymore. I'm done with the skill. My dirty hands can touch the dirty faucet. Perfectly okay. But if you want to use paper towel, you can do that too. But it's not required. Dirty hands can touch a dirty faucet. Clean hands cannot. Good? Okay. So I'm going to turn the faucet on and rinse. I'm going to put that rinse water wherever it normally goes. So if I'm rinsing out urine, I'm going to put the rinse water in the toilet. Okay. Basins are only used by that one person. That's it. They don't get spread around person to person in a facility. I don't get a basin for you and then turn around and use it on you. It doesn't work like that. Basins are single patient use only. So I want you to think about this from your own standpoint. When you brush your teeth, I want you to think about your house. When you brush your teeth, do you guys sterilize the sink after you brush your teeth every time? No. You probably just rinse it out to get the big globs out, right? Once a week, you give it a good scrub maybe, or when company's coming. So we're going to treat our patient basins the same way we treat our sinks at home. We just need to rinse it, dry it, and store it because you don't want warm, dark, moist in the drawer. Good. Sometimes in some care plans, it's going to tell us to disinfect. Some care plans. If our patient is on chemotherapy and we've absolutely obliterated their immune system, we want everything disinfected. Because think about this drawer, right? This is out of our sight. When something goes in this drawer, it's out of our sight. It's protected from light. It's warm. If we put something back moist, we've got some pathogen growth there. So when we have people that have a limited immune system, your care plan will probably tell you to disinfect everything before you put it away, just so that there's no pathogens to be able to proliferate. Make sense? Don't need to do it for everybody, but sometimes our care plan will tell us to do that. So the process that I'm going to show you allows for this to happen. We're going to rinse our basin. We're going to dump the rinse water out, and then we're going to set it down in the sink. Now, if we have to disinfect, that's when we would disinfect it, when we're not touching it. So we rinse it, we dump it, we set it down, and we spray it. Now, for the test, we're not spraying anything. But remember, your dirty gloves can't, or dirty hands can't touch that basin. So once you set it down, whether you spray it or not, you don't want your dirty hands or dirty gloves to touch that basin. So we're going to use a paper towel to pick it up. A paper towel to dry the inside. A different paper towel to dry the outside. And then one more to gather our supplies and open our drawer. So we're not touching our supplies or the drawer with those dirty gloves. Good? Questions? That's basin cleaning. And you throw all your dirty gloves away. You're going to see basin cleaning a lot. Don't panic if you don't get it this time around, because you're going to see it over and over and over and over and over and over and over again. Just remember, simplify it. Everything that we put away has to be rinsed, dried, and stored. Okay? Let's see here. Sharon says, good evening, madam. I'm Sharon from Kenya. Oh, cool. I like these courses. Always follow your classes, though I haven't gone to school due to finance, but I believe one day I will go to school. Oh, well, we wish you the very best of luck, Sharon. Thank you for tuning in all the way from Kenya. That's pretty cool. All right. So these are all of our rules for basin cleaning. So let's apply all of the rules that we've learned so far to this skill. So of course we're going to do our opening, knock, knock, knock. Hi, Miss Jones. My name is Patty. I'm your CNA today. I'm here to do hand care. Is that okay? Close curtain, wash hands, get a barrier, get supplies. Then we'll go over and get water. We'll check it, have the patient check it. Good so far? Okay. We have to decide if we need gloves. So as long as your patient's skin is intact, you don't need gloves. There's no body fluids here. There's no personal skin on their hands. So the only thing we really have to worry about here is open wounds. So if they have open wounds, wear some gloves. If they don't, you don't need them. You're washing your hands before and washing your hands after. So the steps of hand and nail care is we're going to soak the hand in water and we're going to take it out and put it on a towel. Don't just leave it on the table. Tables are hard. So we're going to soak it in water, take it out and put it on a towel. We're going to get a washcloth, wring it out really well, no drippy wet washcloths. We're going to apply some soap to that washcloth, and then we're going to wash all surfaces, everything we see. Once we've washed, we'll put the hand back in the basin to rinse. Because remember, we didn't put any soap in that water. It's good for rinsing. And then we'll take it out, put it back on the towel to dry. Hand washing. We're only doing one. So soak, out to wash, back in to rinse, out to dry. Good? Okay. Then, once we've done that, we're going to take an orange stick and we're going to use the slanted end, the scooping end, and we're going to go under every single nail and clean under the nails. Now, I don't want to take dirt from this nail and put it under this one. So I'm going to clean under the nail and then wipe it off on my towel before I clean the next nail. Wipe that one, clean the next nail. Wipe that one, clean the next one, and so on. And then once we're done cleaning under the nails, we'll use an emery board to file in one direction only toward the center. And that's because nails, as we get older, become very brittle. And if you go back and forth, that's actually pulling and pushing the nail. It'll split right down the center. I have one that's doing that actually. This nail, I have to keep it very, very short because it splits right down the center and it will go all the way down my nail. So can you imagine how painful that is? As we age, this becomes very, very common. So we don't want to go back and forth with an emery board, just one direction toward the center. That way we're never putting that longitudinal stress along the nail. The one thing we have to understand about this is that nail clippers are advanced pieces of medical machinery we're not allowed to touch as CNAs. I know you use nail clippers on yourself at home. We don't use them on patients because the risk of cutting the skin at the edge of the nail is very high. And we're going to find out a little bit later in the program, I think on Wednesday, why it could be a problem if your patient is diabetic or pre-diabetic. So we're going to learn about that a little bit later. Okay, good. If you keep your patient's nails filed once or twice a week, you never, ever, ever have to clip them. Preventative maintenance. Filing is way safer for the patient, and that's why we do hand and nail care. Now, question I get asked a lot is, why do we only do one nail or one hand? Why are we only doing one hand? And it's because for the test, where do those evaluators want to be? At home, in their pools, drinking their margaritas, right? If they watch you soak one hand, wash one hand, rinse one hand, dry one hand, clean under the nails in one hand, and file the rough edges and applying lotion, they know you've got it. They don't need to see it on the other hand. But in a clinical setting, your care plan might say one hand because the other one has an incision or external fixation, which looks like scaffolding sticking out of the hand. Hold it all together. They may have a weeping rash on one hand. There's a million reasons. Go by your care plan. So we're going to apply lotion last. We'll warm it up in our hands and apply it, then wipe off the excess. Good? I'm going to show you the video for this because the video has really good close-ups. Uh-oh. Oh no. Hold on, guys. Try this again.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm doing great. How about you?
Wonderful. I need to do hand and nail care on one hand. Is that okay?
Yes.
I'm going to close your curtain for privacy. Let me go wash my hands, and then I'll gather my supplies.
Okay.
Okay, we're going to start with the barrier. So I'll place the barrier on the table, and that will give me a place to set your clean supplies. And then I'm going to gather a basin, soap, and lotion. An orange stick and emery board. Two washcloths and a towel. I'm going to go get some water in the basin.
Okay.
Okay, Mr. Jones, would you like to check the water temperature, make
Yes,
sure it's
please.
okay?
It's
Is
great.
it good?
Yes.
Okay, you can submerge your hand in there if you'd like,
Okay.
and I'll bring that tray a little bit closer to you.
Thank you.
Is that comfortable?
Yeah.
I'm going to place the washcloths in here, and we'll wet one of the washcloths and use it to get your hand wet. Now I'm going to place your hand over here on the towel. Apply soap to the washcloth. And now I'm going to wash all surfaces of your hand, including in between the fingers, in this area between the thumb and the forefinger. You're going to turn your hand over now and wash the palm of your hand. Now we're going to place your hand back in the basin to rinse. Okay, I'm going to bring your hand over here to dry. I'm going to dry between the fingers. And then I'm going to turn your hand over and dry the palm of the hand as well. Okay. Now we'll take the orange stick and I'm going to clean under each nail. Just cleaning the edge. Does that hurt?
No.
Very good. We'll wipe the orange stick on the towel in between each finger. And now I'm going to file any rough edges. So I'll file from the outer edge to the middle, checking each nail for any rough edges. And now we can apply lotion. So I'll get a little lotion, warm it up in my hands, and apply it to all surfaces of your hand. Does that feel good?
Yes.
Very good. Okay. Now we'll wipe off the lotion. How's that?
Great.
Wonderful. I'm going to place my soiled linens in dirty linen container and then clean up my workspace. I'll be right back.
Okay.
Okay, on the way, we'll pick up the soap and the lotion and place them in the basin. We'll use the paper towel to open the drawer, place the basin in. These items will get thrown away. Okay, Mr. Jones, are you comfortable?
Yes, ma'am.
Can I offer you a magazine?
No, ma'am.
Is there anything else I can get for you while I'm here?
No, thank you.
Okay, your call light is right there. Please use it to call me if you have a need. I'm going to open your curtain and wash my hands. After washing my hands, I'll review the steps of my skill, make any corrections, and then tell the evaluator my skill is done. All right. Any questions on hand and nail care? Notice that did not take 11 minutes. You've got lots and lots of time. So I need you to understand that because most mistakes get made on the state exam because people rush. So you got plenty of time. Good? Questions? No questions? All right, moving on. Okay. Oops, let me go back here. So if you look on page 141, I need to add. Sure.
I noticed in the video at the end when it has to do with the call light, it was the call light's here if you need it. Is that acceptable
So-
for that skill instead of the other ones where it usually says make sure the call light is within reach?
Right.
He was kind of a distance.
So you do want to make sure the call light is within reach. Yes. There are a few skills where the standard says call light in hand. Those I go over like with dressing a resident in their stronger hand. Sideline position will be in the hand. The rest of the skills are all in or near the hand as long as it's within reach. For that skill, I've got the patient out a little bit further away from the bed just because of visualization for camera angles.
So the big thing is mostly just verbalizing, you know, in that one. Here's the call light, recognizing that the patient would need the call light.
Right, right. And that has to be recognized for every skill as part of the closing. So in or near the hand. Okay, good. Good question. All right, so let's move on to making an occupied bed. This is going to be on page 141. So if you look at the principles going down the side of the screen there, you'll see skill rules, opening, glove rules, barrier rules, privacy blanket, linen rules, and we know all of those. And then we get to purple, scoot, and roll. We don't know that one yet, so we're going to get there in just a minute. They're all spelled out here for you. Again, if you just do all of these steps, you will get a perfect score. Cliff Notes version are at the top, test specific information at the bottom, and of course, there's a video for this. So somebody with your level of experience, which is none, should be able to do this skill within 14 minutes. The one thing I'm going to tell you about making an occupied bed, everybody should know how to make an occupied bed that works in healthcare, because most of the time your patients are weak or injured or whatever that keeps them from getting out of bed. So we need to know how to do this. But if you walk by a bed and it's empty, that is the ideal time to change the sheets. I can make an unoccupied bed in about 2 minutes. It takes me about 9 or 10 to do an occupied bed. It's also very stressful on the patient because they've got to scoot and roll and scoot and roll and scoot and roll. So there's a lot that they have to do in this skill. And if you're tired and don't feel good and maybe nauseous or in pain, you're not going to want to do all that moving. So anytime the bed is empty, if the patient is down having a shower in the shower room, or they're in an activity room, or they went down for a test or a procedure, anytime you see a bed empty, your brain should automatically think, wait, do those sheets need to be changed? Because you can do that in like 2 minutes. Easy. Does that make sense? And that saves you time when the patient gets back in it. And let's face it, when you are sick or injured, clean sheets, clean sheets feel amazing on a regular day. But when you're ill or injured and you're stuck in that bed, clean sheets feel amazing. So if you walk by a bed and it's empty, just kind of consider, should I change those sheets? Probably. Okay, good. All right. So we're going to learn the other 2 linen rules. Now remember, we've gone over all the other linen rules before. So linens can't touch your uniform. You have to have clean hands to get the linens. Don't snap or shake them. And anything you don't use, you have to discard. Right? We know those. But we've got some 2 here in the middle that we have to learn. So let's focus on those. Clean rolls toward me. Dirty rolls away. You're going to hear this a lot in this class. Clean rolls toward me. Dirty rolls away. And this is how we change sheets or chucks or anything that's under the patient. Clean rolls toward me, dirty rolls away. And let me explain why. Visual example here. Move over here so you guys can see the screen. So you can see on the screen, we've got a patient in the bed, we've got a clean sheet, we've got a dirty sheet. So let me show you why this principle is the way it is. So we've got a patient laying in bed on a sheet. So patient, sheet, bed. Everybody with me? Now, in order to change that sheet out from under the patient, I've got to remove the old one and put a new one on without letting the patient touch the bare mattress. So this can be a little bit tricky. So we have a method we use here. If you take the dirty sheet, loosen it from the corners, and you roll it toward the patient, the part of the sheet the patient was laying on, the upside of the sheet, the top side of the sheet, that is getting rolled in. So what's facing up here is the underside of the sheet, the part the patient didn't actively lay on. Make sense? Okay. So the cleaner side of the dirty sheet. Now, if I take my clean sheet here and I roll it toward me, again, the underside of the sheet is what's facing up. So if I take this underside of the sheet, right, the bottom of the sheet, the underside, and I tuck it underneath this underside of the sheet, that means that these pathogens aren't transferring. It keeps the sheet cleaner. But I don't want you to lose sight. The thing that has the pathogens is still in the bed. You guys understand that? This isn't sterile. There may be some transfer because the dirty patient is still in the bed. So we're trying to change the sheets, making it as clean as possible, but understanding that we do have some limitations here. because the patient is still in the bed. Good? Makes sense? Okay, so once we have that clean sheet underneath the dirty sheet, we're going to have the patient roll so that they're now on the clean sheet, and we can just remove that. That goes in dirty linen, unroll that, and have the patient back in the middle. And we've just changed that bottom sheet without them having to get out of bed. Good? Pretty cool, right? It's a pretty cool trick to learn. Those of you who are parents, you will use this, making an occupied bed, on kids more than you do at work. Once you've learned how to do this, and you can, especially when you've got kids that are sick and you've got to change the sheets, instead of getting them up out of bed and trying to move them, because that usually gets them crying and starts a whole production. Instead of doing that, you can change the sheets right around them, leave them in bed where they're comfortable. Good? So the clean sheet rolls toward you, so the underside is up. Dirty sheet rolls toward the patient, so the underside is up, and we're going to tuck the clean under the dirty. We don't want anything to touch the floor. Not clean, not dirty, not anything. So when we're doing this, you've got to try to maintain control over the corners of your sheets. You don't want anything to touch the floor. So when you're putting the clean sheet on, you've got to stretch it out on the mattress so it doesn't touch the floor. When you're taking the dirty sheet off, you've got to control it, so we wind it up in a ball so that the dirty edges don't touch anything else. Okay, nothing touches the floor. Any questions on that? So that's a problem. I don't know about you, but when I'm at home and I'm changing the sheets out of my bed, right, I take everything off, all the old stuff, dirty stuff, and I throw it on the floor. Put the new stuff on, and then I gather up all the dirty sheets. I take them to the laundry room, put them in the washer, right? And I probably hold them up against me as I'm walking. So the way that we're used to changing sheets at home can't work here. We have to have a little bit different process, because we're not going to put the dirty sheets directly on the floor. We don't put anything dirty on the floor in healthcare. Patients walk on that floor. So in a healthcare setting, we're going to use either the hamper, but that's usually in the hallway. We can use a chucks on the floor and put the sheet on the chucks, as long as the sheet remains completely on the chucks and doesn't spill over. But most of the time we're going to use this. This is a soiled linen bag. It's very light blue in color. It's actually stamped soiled linen. And you'll find these in your supply closet at work. If you go get a bag, a soiled linen bag, take it into the room with you, open it up, you can set that on the floor, everything goes in. But let me tell you something about these bags. You guys are all familiar with Tide Pods, right? Right? Or Gain Flings will be equal opportunity here. They're little packets wrapped in plastic that contain all of the detergent for your wash cycle. Everybody familiar with that? All right. These bags were the original Tide Pods. So these blue bags, inside the bag itself, the fabric of the plastic of the bag is the laundry detergent. So the whole thing, the bag and all, goes into the washer. And the high heat from the industrial machines melts the plastic, releases the detergent, and washes the sheets. Pretty cool. So why do I bring this up? Well, it means that nobody anywhere is going to be going through these sheets to make sure there's no hearing aids or dentures or earrings or cell phones or anything else in the sheets that don't belong there before they go in the washer. That's our job. And it's amazing how many eyeglasses and hearing aids go through those industrial washers because we don't pay attention. So when you're doing this, when you're clean rolls toward me, dirty rolls away, one of the other reasons we're doing it that way rather than just like, pushing sheets together and making a big bundle ball is when you're doing it methodically, clean rolls away, your dirty rolls away, you're looking as you're rolling, you're looking for any foreign objects, anything that shouldn't be there. Does that make sense? Good. Okay. So yeah, we've had these bags for probably about 30, 35 years. We've been using them in healthcare. And that's because maybe even longer than that, but there were the people that worked in laundry in clinical settings, there was a very high number of accidental needle sticks. It was actually the most dangerous place to work in healthcare because needles would get, left in the beds and the sheets. And at least in nursing, you're controlling the needle. You've got control over it. In the laundry room, they would just take the stuff out, shake out the sheets, and they would get stuck. So we did away with that. And that's why this exists. And those guys are just making minimum wage. I mean, that's not a very good risk. You're not getting paid for your risk. So it's up to us to make sure that we're looking. So you may have a state test question on the written exam. When changing an occupied bed, what is an important observation for a CNA to make? And the answer would be look for foreign objects. Good. So every facility, clinical, acute care clinical facility, I should say, will have 2 specific rooms on each unit. One of them is a clean utility room, and it only holds clean stuff. So your clean supplies, anything clean. And then there's a soiled utility room, and that only holds dirty stuff. Used lunch trays, bags of linens, whatever, dirty stuff. Nothing clean can go into soiled utility. Nothing dirty can go into clean utility. Remember that they're completely separate, and we don't want to cross-contaminate. So be careful there. But this is where your linens will go if you don't have a hamper in close proximity. We don't keep hampers in the patient's room. We don't keep anything dirty in the patient's room. We want patients' rooms to be clean. So we don't have hampers in there. For the test, you will. You'll have a hamper similar to this or a laundry basket that will be right beside the bed for the test. They're making it easy on you. They're making it super easy on you because you don't have to go anywhere. It's right there. But understand that you won't have that in a clinical setting because we don't keep dirty things in the patient's room. Okay, so remember our linen rules, use it or lose it. Don't store items for later use. Once they're out of your sight, they can't be considered clean. So if you take too much, put it in dirty linen. Don't leave it there for later. So now we're going to get to scoot and roll. So scoot and roll is another principle that we're learning. And we're going to get into this a little bit more a little later. I believe on next Monday, I think it is. But we're going to do this like just a brief overview. You're going to see it in practice, but we're going to get into this a little bit more as we go through the program. But with scoot and roll, it's important to understand that we aren't going to have side rails in every setting. Side rails are a restraint. You have to have a doctor's order to use them. You can't just decide as a CNA that our patient is unsafe and put side rails up. It is a restraint. At what age did you start crawling out of your crib? Yeah, probably about 1.5 to 2 years old, somewhere in there. And once you hit that age, no crib is going to keep you in the cage. You've learned how to climb and you are on the run. And all that crib is doing now is increasing your risk of injury because it's much further for you to drop. Well, you stopped liking confinement at 1.5 years old. How many of you guys like to be confined now? At what age are you willing to give that up? Yeah, your patients feel the same. When you put those side rails up, they're not going to keep your patient in bed if they want to get out. All you've done is created an obstacle for them to go over or under or around or through. And you've radically increased their risk of injury. So side rails cannot be used to keep our patients safe. They require a doctor's order. There has to be an actual reason to use them. We don't need them either. So in order to keep our patients safe without the use of side rails, they always have to be in the middle of the bed. It's pretty simple. As long as patients in the middle of the bed, they're safe. And you do this automatically without even thinking about it. You don't even think about this. Let me demonstrate this. You don't even think about it. So I need a volunteer. All you gotta do is lay in bed. Need a volunteer. Okay. Can we move your bag? Just, yeah. Thanks. Okay. So all I want you to do is lay down on your back in the bed. Yep. All right. So I told her to lay down on her back in the bed. That was the only direction I gave her, right? You heard me. Where did she put herself in the bed? Why? Yeah, she did it without even thinking about it. I didn't tell her to do that. Now, she knows she's not staying in this bed. She knows this is temporary. It would make more sense for her to put herself on the edge of the bed because she knows it's temporary, but she didn't. Were you aware of what you did? No. I know. She's like, oh, I did. So your patients do that too. Your patients will automatically gravitate to the middle of the bed because it's where their brain thinks it's safe. Now, can I get you to roll so you're facing that shelving unit? Okay, she didn't roll. What did she do? She scooted. Yeah. So when she rolled, right, she knew that she was going to be too close to the edge of the bed. So she shifted her backside back to the middle of the bed. Did I tell her to do that? I told her to roll. She did that without even being aware of it. Thank you. Good illustration. So why does this matter? Well, it matters because your patients have that same ability. Your patients will always position themselves where it's safe in the bed without you having to tell them to do it because they're pretty smart individuals. We developed this. It's called spatial awareness. We developed this ability when we're about 1.5 to 2 years old. It's when you get out of the crib and you get into a toddler bed. Mom puts something soft on the floor. That way, when you fall out, you don't injure yourself. But this is where your brain starts to realize the space that you have to work with and keeps you safe within that space. This is developed very early in life and is always on, even when you're sleeping. Even when you're sleeping. Like me, I go to bed, I'm dead to the world, man. I don't know. A nuclear bomb could go off and I'd miss it because I'm sleeping. But I still wake up in bed. I don't fall out. That's because this little part of your brain is always on, even when you're sleeping. The part of your brain that's responsible for spatial awareness. This is why you can toss and turn all night long and stay in bed even though you're out. Make sense? 2 things put this thing to sleep: alcohol and certain medications. So with alcohol, it actually puts that little part of your brain that's responsible for spatial awareness to sleep. This is why you can start out the night on a bar stool, but after a couple of drinks, that bar stool gets trickier to maneuver. Okay? You start leaning on stuff. So spatial awareness is affected by alcohol. It's also affected by certain medications. Have you ever gotten a medication that had a little sticker on the side that says may cause drowsiness? Do not use machinery or drive while taking this medication. We know that those medications affect spatial awareness. So remember, your nurses look at your patients and develop care plans. So if we have a patient that's on one of those medications, the care plan will reflect how we're going to keep this patient safe. That's not up to you. Make sense? Good? system is already in place. So if we don't have side rails in all settings and we're going to turn a patient over, we're going to scoot them toward us first so that after the turn, they're in the middle of the bed. We're going to remain behind the patient's behind. Never turn a patient towards you, always away from you. That's because of weight distribution. Gravity will always try to pull them back onto their back. If you've turned them toward you, their back is way out here. You're not going to stop them when they start to roll in that direction. The other reason you never turn a patient towards you, there's no easy way to say this, guys, and I'm sorry if I offend anybody, but you never have your patient eye level with your crotch. Talk about a threat. Your patient is laying down, barely dressed, and highly vulnerable. You turn them so that they're facing your crotch, and that can be an indirect threat. Make sense? It happens, guys. One of the very worst instances of sexual assault by a healthcare provider happened one county north of us in Citrus County. There was a recovery room nurse who was actively raping patients before they came out of anesthesia. Yeah. So you can't assume that this doesn't happen. When I give you these rules, it's because of an event that has happened in the past. Okay. That happened in the 90s. And then he actually escaped from prison. And they caught him. But yeah, he's a really bad guy. Really bad guy. And I actually worked at the hospital that he did that at. So it's really, really important that we understand the reason for these rules. Okay. So never turn a patient toward you. Good. As long as the patient is in the middle of the bed, you win. You win. Doesn't matter whether on their back or on their side, they have to be in the middle of the bed. Okay. Remember that side rails restrict a patient from getting out of bed or moving around freely. It's actually called false imprisonment. You can be charged with false imprisonment for using side rails. And they don't really make your patients safer. Having them in the middle of the bed makes them safer. But this is the real problem with side rails right here. They kill several hundred people a year. Because if you're trying to get out of bed or if you're confused, side rails should never, ever, 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 ever be used with a confused patient. Ever. And that's usually who we use them on. Oh, that patient's confused. They keep trying to get out of bed. We need side rails. If they're confused, they have no safety awareness. That is the worst time in the world to use side rails. The absolute worst time. Because your patient will absolutely get trapped when they're confused. And this kills several hundred people a year. A lot of people say, well, yeah, but we want to keep our patients safe, especially if they're unsteady on their feet or they're a fall risk. We really need side rails to remind them not to get up out of bed on their own. Well, let's play that out for a second. Let's think about this for a second. So we have a patient who's weak. Okay. They're weak. They're fall risk. So we put the side rails up and we tell them, don't get out of bed. You need to call us. Hit the call light when you need to get up. We'll come help you, but don't get out of bed on your own. We'll put side rails up to remind you. Sounds good, right? Sounds reasonable. Until the patient hits call light because they have to pee. And nobody comes. And nobody comes because you're busy. And they wait and they wait and they can't wait anymore. So now they're faced with a choice. They can either go over the side rails and get themselves to the bathroom, or they can wet themselves, which is a dignity issue. Which one are you choosing? Going over the rails every time. Absolutely. That is a dignity issue. I'm not going to wet myself because you told me not to get out of bed. Yeah. I got some words for that. And they will go over, under, around, or through. And then you come in, you catch them in the bathroom. What do? You yell at them. I told you not to get up out of that bed. You're a fall risk. We treat them like they're the criminal. Who was at fault here?
CNA.
Yeah, absolutely. 100%. Side rails do not keep your patients safe. They just don't. But let's look at that a little bit further. Okay. If our patient is weak and a fall risk, if we put them in bed and put the side rails up, they're not getting any exercise at all. They're not doing anything to improve their condition. So did we really help them? No. In fact, you can take an older person, put them in bed. 3 days is all it takes to make them completely bedbound. You can change somebody's entire life in 3 days by making them completely bedbound. Their muscles atrophy, their joints lock up, and they will not get back up on their feet. That's a horrible, horrible amount of power that we have over somebody else's life that isn't going to impact us at all. So all of these reasons are why side rails have become a hot button issue. Good. Questions? All right. So side rails require a doctor's order. Now there is a difference between side rails and half rails. So this is a half rail, or what's called a positioning rail. It's got handholds. It doesn't restrict our patient's ability to get out of bed, right? Because we swing our legs out, not our top part. So we swing our legs out. So this patient can still get out of bed. This is a positioning rail or a half rail. These are okay. You can use these. But if I pull this one up, now that restricts my patient's ability to get out of bed. This makes it a side rail. In most clinical settings, you don't even have these on the bed. They have taken them completely off the bed because we can't trust you. We cannot trust you. So we've taken them completely off the bed. And if we get an order for side rails, maintenance has to come and put them on. So the reason is, and I'll give you a great case for this. Now, this happens all the time, but this one just happened to get caught. Night shift at a nursing home, would go in, give every single patient Benadryl, put them all in bed, put the side rails up, and then they'd play poker in the back room. Yep. Now, if you're paying $9,000 a month for your loved one to be in a nursing home, is that how you want them treated? Yeah. And unfortunately, that particular one, the way they got caught, oh. So one of the patients in there was some sort of a legislator's mother. And he was in town and came in after visiting hours to see his mom. And they tried to keep him from coming in. And he said, absolutely not. I am here. I'm going to see my mom. And went in, and he noticed that absolutely every room that he went by, patients were in bed with side rails up. He's like, it's like 7:30 at night. This is not, something's wrong here. So that's how they actually got found out. And that's why this became a law. You want a law? Make it make sense to the legislators. You know, make it be important to them. If you need, here, let me get you a towel. Got it? Yeah. Okay. There's more towels if you need them. All right. So do you understand the difference between side rails and positioning rails? Okay. Remember, the patient must be in the middle of the bed, what we call the safe zone, never toward the edge. So a couple of these skills that we're going to learn how to do, If you look at the patient and notice they're too close to the edge of the bed, address it because the evaluator saw it. So if you get them to scoot towards you and then roll to the middle and they're not really in the middle, do it again. Have them scoot back towards you. You need to address that. So that is an unsafe position. Keep that in mind. That is an unsafe position. So as long as you have them scoot towards you and then roll away so they're in the middle of the bed after the turn, you're good. Okay. So when we talk about bed position, there's a couple of different positions here. You've got the entire bed up and down. You've got the head of the bed up and down. You've got the foot of the bed up and down. So we got a lot of different ways that we can maneuver beds. At the end of the skill, the entire bed needs to be low. Head of the bed is up to the patient, whatever they want. If they want to sit up and eat or watch TV or whatever, that's fine. If they want to put their head down and take a nap, that's fine too. Whatever they want at the end of the bed, unless our care plan says otherwise. But the entire bed must be down. All right. So when we do this skill, making an occupied bed, we want to keep the patient from lying on the bare mattress. We're going to replace the sheet and on one side of the bed at a time. Clean rolls toward me, dirty rolls away. We'll remove the bottom sheet, secure the clean sheet on the mattress corners, smooth out any wrinkles. I want to stop there for a second. Wrinkles contribute to bed sores. So you want to try to get this sheet as smooth as possible. You're never going to get it completely smooth because you've got a patient in the bed. But you don't want it all rats nested up underneath them. You want it as smooth as possible. Now, in an upcoming lesson, we're going to learn why wrinkles contribute to bed sores. But for right now, I just need you to know that concept. We'll go over the why a little later. We'll replace the top sheet and make hospital corners. I'm going to show you how to make good hospital corners. This is not a good hospital corner. Right here. This is not a good hospital corner. We're going to learn how to make good ones, but it requires that the sheet gets underneath the mattress flat. Not just shoved down. It's got to go flat under the mattress. The video will show you exactly how to make hospital corners. But for those of you who are a little intimidated by this, the entire purpose of a hospital corner is to not have a corner of the sheet touching the floor. So if you can't get a really nice hospital corner, which we get like this, okay, that's a really nice hospital corner. If you can't get a nice hospital corner, remember the corner of the sheet has to be not on the floor. So if all else fails, get that corner of the sheet under the mattress and it counts. Okay, doesn't have to be pretty. I would like it to be pretty, but it doesn't have to be pretty. All right, so if we look at page 142 at the top of the page, you've got our care plan for this skill. Care plan tells us to change the top sheet, bottom sheet, and pillowcase while the resident remains in bed. Resident can roll and move as directed, but cannot get out of bed. A bedspread, blanket, and draw sheet or underpad are not required for the skill. So easy. Bottom sheet, top sheet, pillowcase. Easy. Okay. But if you look at the bottom page 142, you'll see the process for 143, sorry. The second column 143, you'll see how to add in a draw sheet or a bed pad if you need to. For the test, it's not required. All right, good? Let me show you this one. Oh, good morning to you too. If a Ninja says good morning to Nurse Patty and everyone. All right. Present. Video. Occupied bed. After this video, we'll take a quick break.
Hello?
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
Good, how are you?
Wonderful. I need to change your sheets. Is that okay?
Yes.
I'm going to close your curtain, wash my hands, get my supplies, and I'll be right back.
Okay.
We'll start out with a barrier. I'm going to get a top sheet, a bottom sheet, and a pillowcase, and a privacy blanket. Okay, Mr. Jones, I'm going to place this blanket over you. This will help protect your privacy and keep you warm while we do this skill, okay?
Okay.
Okay, I'm going to spread this out. Can you hold that blanket in place?
Yes.
And I'm going to remove the sheet from the bed. We'll place the sheet in dirty linen. Mr. Jones, can I get you to scoot toward me, please? Thank you. And can you roll so that you're on your side facing in that direction? Thank you. I'll remove the two corners of the sheet from this side of the bed. And I'm going to roll the soiled sheet in toward the patient, tightly. I'm going to tuck it up underneath the patient all along the length of his body. Now I'll take the clean sheet, unfold it, spread it out on the mattress, and attach the corners. Now I'll roll the clean sheet toward me. We'll roll it so that it's tight with no wrinkles as we tuck it under the soiled sheet. Okay, Mr. Jones, come on back onto your back, and I need you to scoot to the center of the bed, please. Thank you. Can you scoot toward me, please? And can you roll so that you're laying on your side facing away from me? Thank you. I'll now remove the sheet from the bed that was soiled, wrapping it into a ball. And I'll go place this in dirty linen. Now I'll unroll the clean sheet and secure the corners on the mattress. As I do so, I'll make sure to stretch the sheet so that it's flat and minimize the wrinkles that are underneath the patient. Okay, Mr. Jones, can you come back onto your back, please? And scoot to the middle. Thank you. I'm now going to place the top sheet over you. And I'll remove that bath blanket now. We'll roll it in a ball and place it in dirty linen. Now I'm going to secure the sheet. I'm going to lift the mattress and smooth the sheet down so that it's flat under the mattress on both sides. Now I'll make hospital corners by lifting the top edge of the sheet about a foot from the end of the mattress, straight up. It'll form a triangle. Everything else will get tucked underneath. I'll repeat that on this side. And I'll loosen this over his toes so he has some wiggle room. There, how's that, Mr. Jones?
Perfect, thank you.
Very good. I'm going to remove the pillow from under your head. I'll bring it right back. I'll remove the pillowcase, being careful not to allow it to touch my uniform, and lay the pillow on the overbed table. We'll place the pillowcase in dirty linen. I'll take the clean pillowcase and scrunch it up all the way to the edges. We'll put the tag side in, place the pillowcase on top of the tag side of the pillow, and pull the sides down.
You don't want to hold it under your
I'll now place the pillow under his head with the opening facing away from the door. How is that, Mr. Jones?
Perfect, thank
Are you comfortable?
Yes, ma'am.
Here's your call light. If you should need anything at all, please don't hesitate to call. Can I get you something like a magazine?
No, thank you.
Okay, I'm going to open your curtain and wash my hands. The barrier will be thrown away. After washing my hands, I'll think about the steps of my skill, make any corrections, and tell the evaluator my skill is done. All right, any questions? No? Okay, let's go ahead and take our break.
so much to do on break.
Okay. All right. So, any questions on the two skills we've gone over so far? No? Okay. So, we're going to start a new skill here. This is range of motion. And unfortunately, we did not do range of motion on Wednesday. So I'm not going to have all the slides. We're basically jumped ahead. So some of this I'm going to have to do verbally. Just kind of bear with me, okay, for this skill. Range of motion is very easy. It's a short skill. Somebody with your level of experience, none, should be able to do the skill within 4 minutes or less. So super short skill. Okay, this is going to be on page 78. Nothing new to learn. You know the skill rules, you know the opening, you know to evaluate if you need gloves, you know the closing, nothing new to learn. So we're going to focus just on skill-specific steps now. And specifically, we have to learn what range of motion is and why we do it. Okay. This won't take me long to teach you, and then we're going to jump into blood pressure. Blood pressure is a highly technical skill, a lot of moving parts here. So we're going to get through range of motion quickly and then go right into blood pressure. Blood pressure is not on the state exam. So it's not a skill that you're going to have to perform for the state exam, but we still have to know how to do it. All right. So if you look at the top of page 79, you'll see the care plan. Care plan tells us to provide the following range of motion exercise to the resident's right elbow and right wrist. Flexion, extension. That's our exercise. Right elbow and right wrist, that tells us where. Flexion, extension tells us which exercise. And then it goes on to tell us to do 3 repetitions. So that tells us how many. And that's what we need to know for every range of motion that we're going to do forever. What exercises, what body parts, and how many repetitions. So think of it like a recipe. As long as you follow the recipe, it'll come out fine every time. Okay. Good. We got step-by-step instructions. There's no supplies required for this. This is actually a very easy skill. We're going to follow the care plan. Remember, hold on, let me go back here. Okay, this is the wrong care plan. I thought so. So we're going to skip that one. So remember, the care plan is going to tell us which body part, which exercises, and the number of repetitions. We need that information in order to do this skill properly. Now, there's 3 exercises we can do as CNAs. There's flexion extension, which is an up-down motion. There's abduction adduction, which is a side-to-side motion. And then there's rotation, which is an around motion. This is what we do as CNAs. Now, this is where I don't really have slides for you, so bear with me. As healthcare workers, there are 2 reasons to do exercises, and unfortunately, we kind of get stuck on the first one. So when we're doing exercises for healthcare, we tend to think that we're doing exercises to make people better, to improve their situation. But that's actually not us. Do you guys know what department does exercises to make things better? Physical therapy, that's right. Now, those people have to have a doctorate degree, 10 to 12 years of training to learn how to do exercises to make things better. How long are we here?
4 weeks.
Yeah, that's not us. So we aren't doing things to make or exercises to make things better. We're just trying to do exercises to keep things the same. Okay, maintain. So the way that we remember this is that physical therapy, or all therapies, perform strategic exercises to regain function, get something back. CNAs do exercises to retain function or keep what we already have. Make sense? Okay. So we aren't going to say things like no pain, no gain. Not us. We aren't going to force and stretch things beyond their natural limits. Not us. What we are going to do are very strategic exercises to keep the patient's current level of function. Now, that doesn't mean that they are going to start out with a full range of motion. If the patient gets to here and says, ow, then the next one goes below the ow. We don't get to here and they say, ow, and we say just a little bit more. No, it's not us. Okay. We always go below the point of pain. So we're looking for resistance here. Your patient will give you all kinds of clues that things are hurting. They wince, they grimace, they stiffen up, they turn away. There's a lot of, you want to pay attention. There's a lot of clues that your patient can give you that this is not going very well for them. Remember, we don't do pain. Very important. So the 3 exercises that we do is flexion extension. That's something like this, up, down. We extend our arm like we're asking a question, and then we bring it down, which is actually a flexing. So some joints are naturally flexed, some joints are naturally extended. My shoulder, naturally flexed. It's in the folded position. My elbow, naturally extended in the straight position. If I did this, now the elbow is flexed. So flexed is bringing a body part together. Extending is straightening the body part. Good? Okay. Abduction. When you abduct a child, you take it away from its family. Don't do that. That's bad. Okay. But when you abduct an extremity, you take it away from its family. So we bring it out, away from its family. To adduct, ADD, means to return it back where it belongs. Good? Okay. Now I want you to pay attention to my hand here real quick. Okay. So flexion, extension, notice where my hand ends up. Okay, see it here? Flexion, extension. Now, abduction, adduction, notice where my hand ends up. Same place, but facing a different direction. Flexion, extension, my hand was facing this way. Abduction, adduction, my hand faces this way because it works different muscle groups. Good? Now let's talk about rotation of the shoulder. Rotation of the shoulder is not what you think it is. When we think rotation, we probably think pitcher windup. That's actually not rotation. Everybody stand up for a second. If you put one of your arms out to your side, try not to hit the person next to you, but put one of your arms out to the side, palm up. Now, I want you to roll that arm all the way over so it's palm up backwards. Feel what that does inside your shoulder. Come back forward, around, forward. Do you feel that inside your shoulder? Some of you are probably snap, crackling, and popping. Go ahead and have a seat. That is rotation of the shoulder joint. It's a completely different motion than a pitcher windup. Okay, good. Not all joints can rotate. Your elbow cannot rotate. Your elbow is a hinge joint. It only goes up and down. That's all it will ever do. If you get an elbow to do something other than this, you broke it. Okay, this is it. It's all an elbow will ever do. But your wrist is an articulating joint. It moves in all different directions. It can go up, down. It can go side to side. It can go around. It can do all kinds of stuff because it's an articulating joint. So it's not up to you to know which joints move in which directions. It's up to you to follow the care plan. Okay. So this care plan tells us to do range of motion of the elbow and wrist flexion extensions. That just means up, down. So we're always supporting from below with a flat palm. We're going to move slowly and smoothly and always return to the start position. So if we're going to do flexion extension of the shoulder and I go up and I only go back down to here and they go, that's not a full range of motion. When I go up, I have to come all the way back to start for it to count. All the way up, all the way back to start for it to count. Okay, halfway doesn't count. Good. Move slowly and smoothly, return to the start position. We want to monitor for discomfort, pain, grimacing, wincing, turning their head, stiffening up, saying ow. Those are all big clues that this is hurting the patient. We don't like to hurt. Every skill starts with the opening. So this skill would start out, knock, knock, knock. Hi, Miss Jones. My name is Patty. I'm your CNA today. I'm here to do some exercises on your right elbow and wrist. Is that okay? You can say range of motion. You can say exercises. You can say, I'm going to move your arm around. You can say it any way you want to. Just make sure the patient understands what you're planning on doing so you can get consent. After you get consent, you'll close curtain, wash your hands. There's no supplies for this, so we'll start the skill. Make sure you inform your patient all the way through what you're doing. And at the end of the skill, we're going to do the closing. Thank you very much, Ms. Jones. Is there anything else I can get for you while I'm here? Are you comfortable? Your environment's clean. Bed is in low position. Here's your call light. If you need anything, let me know. Open the curtain. Wash my hands. Okay. Opening at the beginning, closing at the end. For gloves for this skill, you have to look at the patient. If they have this, there's no personal skin, no body fluids here, right? It's the elbow and wrist, nothing there. But if they have any open skin, we would need to wear gloves for this one. So, support our extremity near the joints. Lift from below with a flat palm. Move slowly and smoothly. Return all the way to the start position. Abduction or flexion extension is up, down. Abduction, adduction is side to side. Rotation is around. And ask about pain or discomfort frequently. Questions? Pretty easy, right? This is literally a 2-minute skill. And there's nothing to it. So let me get somebody to come over there and lay down in that bed. Okay. Make sure you pay attention to which body part we're exercising. This is their right elbow and wrist. I'm going to simulate hand washing for the sake of time. Okay. Hi, Miss Jones. My name is Patty. I'm your CNA today. How are you? Fantastic. I need to do some range of motion exercises on your right elbow and wrist. Is that okay?
Yes.
All right. I'm going to close your curtain. Let me go wash my hands, get my supplies. I'll be right back. I have clean hands. All you have to do for the exam after your first skill when they tell you you can simulate. I have clean hands. All right, Miss Jones, I'm going to do all the work. All you have to do is let me know if there's any pain or discomfort as we do this. Now, you can raise the bed up to a comfortable working height if you want to. Perfectly okay. But at the end of the skill, if you raise the bed up, what do you have to remember to do? Yeah, and unfortunately, at the end of the skill, you're going to be in a hurry because you just want it over with. And chances are you'll forget to put the bed back down. So be careful if you decide to raise the bed. Okay. I'm short. I bend. I won't raise the bed. All right, Miss Jones, I'm going to do all the work. All you have to do is let me know if there's any pain or discomfort as we do this. Okay. So I'm going to place your arm palm up. We're going to bring it up like you're making a muscle and all the way back to the bed. That's 1. You okay? Up for 2. Back to the bed. Still good? 1 more. 3. All the way back. Good job. All right, now we're going to move on to the wrist. We're going to make a very loose fist, and we're going to bend forward and back like you're revving a motorcycle. Okay, so forward and back. Feel okay? Forward and back. Still good? And forward and back. Good? All right. Can I get you to lean forward just a little bit? There we go. All right. Are you comfortable? Is there anything else I can get for you while I'm here? Okay, call light is right there. If you need anything at all, just press the red button, and I'll be in to help you. I'm going to open your curtain, wash my hands, think about the steps of my skill, make any corrections, and tell the evaluator my skill is done. That did not even take 2 minutes. Okay, good. So now for you guys, if you go home and watch that, you'll see the top-down view. All right. Okay, any questions on what we've gone over so far? No questions. We're going to move on now into blood pressure. Now remember that blood pressure is not tested on the state exam. This is not something you're going to be asked to do on the test. Now, everything else we've gone over is, but not this one. You are required, however, to know how to take a blood pressure because this might show up on the written test. Normal values will definitely show up on the written test, but you won't have to physically demonstrate this. So if you go to page 56, are the notes for what we're going to learn to do together. So the first thing that we have to understand is what is a blood pressure? What is this? So we talked last week about having a heart. That heart squeezes and pushes out a wave of blood. That wave pushes the one in front of it. That wave pushes the one in front of it, and so on as blood moves through the vascular system. Right? You can actually see that here. When the heart contracts, it pushes out a wave of blood. That one pushes the one in front of it. That one pushes the one in front of it. Okay? So if I were to cut open an artery, that's what it would look like. Now, when a wave is moving through, there's more pressure. When the wave is done moving through, the artery has less pressure. So let me explain this in a way that's a little easier to understand. Let's say that we have a hose faucet on the outside of our house and we've attached a hose to it. And we stand at that faucet and we turn the water all the way on and then all the way off. So when we turn the water all the way on, water flows through the hose expands, gets bigger and harder. Lots of pressure in there, water pressure. When we turn that hose all the way off, the water stops flowing, goes to a trickle, the hose shrinks, less pressure. Everybody got that? Good visual for you? Okay, that's all the heart is doing, is it's standing at the faucet and going on, off, on, off, on, off, on, off, on, off, on, off, about 70 times a minute for your entire life. Doesn't ever take a coffee break. Poor heart. Okay, so when the wave is moving through, there's more pressure. In between waves, there's less pressure. So all we're doing is trying to figure out how much pressure is in that artery when a wave moves through and how much pressure is in that artery in between waves. Top number, bottom number. You know how blood pressure is always 112 over 70? You know, it's top number over bottom number. Top number is representing how much pressure is inside that artery when a wave is moving through. Bottom number is how much pressure is inside the artery in between the waves. All we're doing here. How are we doing it? Well, whoever came up with this, pretty ingenious. I got to admit, pretty ingenious. So we're going to use a gauge. We call it a sphygmomanometer. That's its technical name. We call it a blood pressure gauge because it's way easier to say. But this is a sphygmomanometer. We're going to inflate all the way up to somewhere between 160 and 180. That's all we do as CNAs, because CNAs do
Care plan.
what? Care plan, normal. Yeah, I heard it, normal. CNAs do normal. So anything over 180, is that normal? No, not even in a upside down world. So we only go somewhere between 160 and 180. That's it. That's it. If you go over 180, it hurts. Do you know what effect pain might have on blood pressure? Say it louder. Makes it go up. So if we're inflicting pain on our patient and we get a high reading, maybe it wasn't like really high. It was because they're under pain right now. Do you see how that can skew things? So as CNAs, we only go up somewhere between 160 and 180. That's it. If the blood pressure is over 180, that has to be reported to the nurse. We don't need to know what it is. It just needs to be reported to the nurse. Okay, good. So as CNAs, we go up to somewhere between 160 and 180. We slowly deflate that the air out of your gauge, so that needle's going to start to come down as we're deflating. And we're going to listen for the first thump and the last clear thump and go all the way to 0. That's it. That's all we're doing. That's it. That's all a blood pressure is. You're listening for the first thump and the last clear thump. That's it. Where the needle is when you hear the first thump, that's the top number. Where the needle is when you hear the last thump, that's the bottom number. That's all a blood pressure is. There's nothing complex. We're not counting anything. There's no math involved. It's just listen. Okay? So not hard. Does take eye, hand, and ear coordination, though. Okay. So we need 2 pieces of equipment to do this. We're going to need a blood pressure cuff that has that gauge. And we need a stethoscope or a microphone to listen. Because remember, we're listening for where we hear the first thump and where we hear the last clear thump. So we need a microphone to listen for that. We call it a stethoscope. Good? So let's talk about the pieces of our supplies. So the first thing we're going to talk about is your blood pressure gauge or cuff. Go ahead and take them out if you've got them with you. These are not one size fits all. They're one size fits most, but not one size fits all. Now, some of you need to put your kits together, so let me help you with that. Do not inflate your cuff unless it's wrapped around something. Do not stop. Do not inflate your cuff unless it's wrapped around something. Oh, yours is good. Okay. Everybody got your pieces together? Okay. Some are easier than others. Yours good. You're good. Everybody good? Okay. All right. So you have a gauge and you have a bulb and valve assembly. These are the two things hanging off. The gauge is heavy, has a clip on the back. If you press down on the bottom of the clip, the top magically opens. You want this firmly attached to your cuff. I know it has prongs, but if you just lay it there, if you just connect it by the prongs, when you go to take this off of a patient, if that falls, their wrist is right there and this is heavy. We don't want it to fall onto our patient. So if you press down on the bottom of the clip, the top opens. There's going to be a little fabric tab. Okay, those of you, oh, hold on. Those of you that have a bar, if your cuff looks like this and you have a bar, do I have anybody that has a bar? Okay. Those of you with a bar, you will not have a fabric tab that I'm talking about. Okay, because these are for self blood pressures. So the rest of you with the professional cuffs, you will have a tab, a fabric tab. If you open your clip, slide it up that fabric tab, it'll stay there. Okay, good. Good, those are fine to practice with. All right, this is your measuring guide. This tells you whether this cuff is going to fit your patient. If I have a patient with really teeny tiny arms and I'm concerned that this might be too big for them, I can actually measure it. Can I get you to take your jacket off and come up here? Yep. So I'm concerned that her arms might be too small for my cuff. So the way I would find that out is I take this white stripe. So the professional cuffs have a white stripe. I'm going to put it up underneath her arm at about 1 inch or 2 above her elbow. I'm going to wrap it all the way around. If it wraps more than halfway around her arm, it's too big for her. And I'm not going to get an accurate reading. This is like borderline. Okay, good. Thank you. If I think my patient, if their arm might be too big for the cuff, I would wrap it around. And if I can't see either corner underneath the arm, it's too small. More than halfway around, too big. Can't see either corner, too small. Anything else will work. Okay, so this is one size fits most. If we're not using the right size cuff, we're not going to get an accurate reading. Good? Okay. All right. So right now we should have a cuff that has a gauge attached and has a bulb and valve assembly hanging off of it. This bulb and valve assembly is what inflates and deflates the cuff. Please do not put air into your cuff unless it's wrapped around something. There's a bladder in here. If it doesn't have anything to press against, it can actually blow, and now your cuff is no good for anything. These are designed to meet resistance, okay? The arm specifically. So don't ever inflate or deflate this unless it's wrapped around something. All right, so this dial is what's going to let air in and out of our cuff. Let me show you. I'm going to get a can here. So we'll pretend this is an arm. My cuff goes around the arm. So my gauge faces me. I'm just going to fold this out of the way. This bulb and valve assembly is how I'm going to inflate and deflate this cuff. When I hold this in my hand, notice the ball is in my palm, not like this. The bulb is in my palm. And I need to be able to, this little silver dial needs to face me. I'm going to have my thumb and index finger on that at all times. So if you were to stand over my shoulder, this is what it would look like. The bulb is in my hand. My fingers, my thumb and index finger are controlling this little silver valve, and the gauge is facing me. Okay. So what we're going to do is you're not going to do anything yet, you're just watching, is when I'm holding this, I'm going to turn that valve righty-tighty. So I'm going to turn, as it's facing me, turn that valve to the right just until it stops. Don't crank it down. We're about to loosen it. If you really like crank it down, you're not going to be able to loosen it in a minute. So I'm just going to turn it till it stops. And then I'm going to pump this until my needle goes up to, how far do we go? Yeah, 160 to 180. And once it's there, then I'm going to take that little silver dial and I'm going to turn it ever so slightly to the left. When I say ever so slightly, I mean Thumbelina type motions, hairs. You can barely even see it. So I'm going to turn it ever so slightly to the left, and I'm going to keep turning it. It's not a crock pot. We can't set it and forget it. As it slows down, I'm going to open it a little more, 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 so that I get that nice, slow, controlled rate all the way to 0. Good? So let me show you on screen. Okay. So we've got our gauge here, and we've got our bulb and valve assembly here. Let's see if I can do this without. There we go. You guys see that? So I'm turning this silver dial to the left just until it stops. I'm going to squeeze up until 160 to 180. And now I'm going to hold this between my thumb and forefinger. I'm not going to let it go, and I'm just going to open it ever so slightly. You see how little I'm opening that? You see how it's just teeny tiny? And I want that needle to look like this. All the way down. And I'm in control of that needle. If that needle stops, that's me. See how that needle stopped? That's not the needle, that's me. I have to open that up for that needle to come down all the way to 0. Good? You guys understand how that works? So this gets wrapped around your arm or your patient's arm with the gauge facing you. You hold the bulb in your palm with your thumb and index finger on that silver dial. You turn the silver dial to the left just until it stops. You pump up to 160 to 180, and then you slowly open that silver dial ever so slightly to the left. Don't let go of this dial. If you let go, when you try to grab it to open it a little more, it'll either tighten it or loosen it too much. So once you have your fingers on it, keep them on it all the way to 0. Good? Okay. So I'm going to pass cans around for you guys to practice on. Oh, good, you've got one. Okay, so give yours to somebody back there. I need to give you a different one. You also, okay. Those of you who have the bar, let me take that one. Let me see here. You've got a bar. Try it on your cup. Your cup might actually work because that's a little bigger. So we're going to do it this way. Yeah, that'll work. Okay, so that one will work for you. Yeah, I'm going to have to get you something else. Let's see here. Which is that one mine? Is this one mine? Okay. Thank you. Try this one. It's a little bit, so you're just going to slide this right in.
I'm so sorry.
Oh, no, you're good.
Another one.
There we go. You're good. You're good. Okay. So put your cuff on your cylindrical object, whatever that is. Make sure the valve is facing you. You want to hold it in your non-dominant hand. And in your dominant hand, you want to hold the bulb and valve assembly with the bulb. There you go. Good. Yeah, it's fine. With the bulb in your palm. Turn that valve, that silver valve, to the right, just until it stops. You're going to inflate and deflate and give it a good couple of tries. I don't have another one for you, so can you guys share? Okay. So, okay. She doesn't have a cuff. So, oh, thank you. Thank you. There you go. All right. Practice inflating and deflating a couple of times. So until you get it down, until you get the mechanics of it. Remember, if that needle goes woo really fast, that's you. If the needle stops, that's you. You are in control of the speed of the needle with that little silver dial. So give it a couple of tries. That needle should look like a second hand going backwards, but about that speed. That's what we're looking for. Open it up a little bit more. So when you're tightening it, don't tighten it quite so much because that's what makes it hard to get it started. So good job, though. Good control. Good control. Nice control. Go ahead and inflate it for me. No, we only go up to between 160 and 180. Don't go that far. Slow down just a little bit. There we go. Oh, that's good right there. Very good. That's your rate. That's what you're looking for. Oh, beautiful. Nice. Okay. Let's go ahead and try. Try. Okay. Open it up. Too fast. Yeah. We're going to talk about what you see in just a minute. We're going to talk about that. Can you inflate for me?
Yes, I know. I shouldn't have said that. It's
That's
not
good.
necessarily what you see is where you
Open it.
measure it.
Yeah. We'll talk about that. I've got a visual that I'm going to show what that, because that's very, very common. Yeah. There you go. Let me see. Yeah, you'll want to work on making it just a little bit smoother. A little bit smoother. But overall, good. Little practice goes a long way here. A little practice goes a long way. Come around here.
She did good. She did good.
Okay, good.
Those two did
So you want to do this with just one hand because your other hand's going to be busy in a minute. Your other hand's going to be holding a stethoscope. So you got to get used to doing this whole thing with one hand. Can you inflate for me? A little bit faster. There you go. Good. We want to keep that rate all the way down, which means we have to keep opening it a little more, a little more, a little more. Let me take a look. You need to do it with one hand, not two. There you go. Are you right-handed or left-handed? Okay, that's good. Good. Good control. Good. Okay. All right. So do you guys have an idea about the mechanics here? Or let me put it a different way. Do you guys think you have an idea about the mechanics here? All right. So once we close our valve, we're going to inflate to between 160 and 180. That's going to bring our needle up. Once we get to that 180 mark, somewhere between 160 and 180, we're going to stop inflating and then deflate so that needle comes down. But let's talk about what's happening in the body when that's happening, okay? So this is an illustration. I just want to make sure everybody can see. This is an illustration to show you what is actually going on inside the arm when we're inflating and deflating the cuff. Okay, good. All right, so we have a heart. That heart is beating. The heart never stops beating because if it does, you're dead. We don't want the heart to stop beating. So as the heart is beating, it's pushing waves of blood down the arm. When we put a cuff on and we inflate, we're using air to squeeze that arm. And when we do that, the muscles that are around that artery are going to squeeze the artery closed. So what we're doing is actually closing off this artery. Good? Okay. So this is what it's going to look like when your needle is up here. Guys, this hurts. This hurts. The longer you have this on, the more it hurts. And remember, pain increases blood pressure. So we want to do this somewhat quickly. We also don't want to do it over and over and over and over and over again because it will affect our blood pressure. Our rule of thumb is twice on one arm and then move to the other arm. If you can't get it there, move to another patient. But don't just take the blood pressure over and over and over again. There's a principle here that you need to understand. When blood slows down or stops, it clots. That is what blood does. When blood slows down or stops, it clots. So if you're taking a blood pressure on your loved ones at home and you're just doing it over and over and over and over and over and over on that same arm, you're stopping that blood and you're increasing the likelihood of blood clots if they have any risk factors. So twice on one arm, move to another arm, move to another patient. Good? Okay. So we've squeezed that artery closed. Now, remember, the heart is still beating, so we've got some waves that are waiting to get through. They can't get through. The artery's closed right now. It's like a toll booth. closed, can't get through. But those waves are still stacking up. Anybody ever been to a concert, like a rock concert? You know, in what they call the pit or general admission, right? There's no seats. It's just people, right? So when people behind you start pushing, what happens to you? Right? You get pushed, right? Make sense? Everybody got that? All right, remember, we got a heart over here that's pushing out more waves. When those waves get to the arm, it pushes all of these waves, which hits the cuff, and you see a tick. Now, all that tick is another wave joining the party. That's it. It's a mechanical action. This is picking up the pressure from another wave because all those waves are pushing down. They're trying to get through. With every heartbeat, they're pushing. We see that as a mechanical action in the needle. You'll see it tick. The tick is not the blood pressure, but it is kind of like the coming attractions. It says, hey, pay attention, heads up, show's about to start. Okay, so ticks are not the blood pressure. It's what we hear, not what we see, but it can be useful in telling us that it's starting.
Which is why it's important not to go so fast.
Right.
That's a miss where you're anticipating you should be hearing what you're seeing.
Right, right. So we want to make sure that we're slow at this just so that we can say, remember, if your needle goes, woo, yeah, they're not, there is no blood pressure there. You're not getting numbers. You're guessing. All right. So when we get to 180, we've closed off that artery. Now we're going to turn that gauge counterclockwise. And that's going to cause our needle to come down because we're deflating. We're letting the air out of that cuff. Okay, so close, put air in. Open is going to let the air out in a controlled manner. So that needle is going to start to come down counterclockwise. And as you deflate, that artery gradually opens. And eventually, one of those waves is able to make it through. So it travels through. And when it travels through, you're going to get to hear it with your stethoscope because that artery is still very small, compressed. And the wave, the top of that wave will hit the top of the artery and it makes a thunk sound. That's what we're listening for. We are listening for a wave of blood hitting the top of an artery buried under muscle, fat, and tissue. Not a big sound. Small sound. So we've really got to be in a quiet environment to pick this up. But we've also got to teach our ears what to listen to because you're going to hear a lot of other sounds too. You'll hear the fans. You'll hear the AC. You'll hear people's legs jiggling. You'll hear your own joints creaking or tubes rubbing together. There's a lot of other sounds that can be amplified here, not just the wave of blood. So this is where practice comes in. It takes about roughly 45 blood pressures before you actually start to get accurate. You're not going to be accurate today. Please don't ask me to double check your readings. You will not be accurate today. Okay, good. You're guessing today. And guessing is okay. We're learning. This is the time to guess. But you've got to get about 45 blood pressures in before you really start to dial this in. Good. So that means that this week, your homework is to find anybody that is somewhat upright. If you can tackle them, take their blood pressure. But we don't want to take blood pressure on little guys. Nobody under 13. This hurts arms. We don't want to make somebody afraid of medical just because we want to practice. So nobody under 13. Nobody over 80. They've got their own health issues. They don't need to be your guinea pigs. If they're between 13 and 80 and you can tackle them, you should be taking their blood pressure. Neighbors, friends, friends of neighbors, neighbors of friends. Anybody that you can get. That's how you get good at blood pressure. But if you're taking blood pressure on the same person at home over and over, like your spouse or friend or significant other, you'll just start to get used to what theirs sounds like, and everybody sounds different. So you want to mix this up. You want a wide variety of blood pressure opportunities. Most people are pretty willing to be a patient for this. They really are. Okay. I had one student who she lived in a little community where everybody was really close. So she set up a card table out front, put a big sign, free blood pressures, and everybody in their community came and let her take their blood pressure. So there, you can get creative with this. Okay. You can get creative. But as we deflate the cuff, waves move through. We're going to hear the first wave. Wherever that needle is, when we hear that first thump, that is our top number. Now, if the first wave made it through, the rest of them are going to be able to go. So you'll hear more thumps. Thump, 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 thump. We don't care about those. They make no difference. Thump, 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 thump. What we're listening for here is the last clear thump. Because at some point, as these waves go through and the artery gets bigger and bigger and bigger, the waves are going to stop hitting the top of the artery because now it's wide open and our thumps will stop. So what we're listening for is the last clear thunk that we hear. So the first thunk is our top number. We're going to hear more thunks. We don't care about those. We're listening for the last clear thump. And when we hear that last clear thump, where the needle is on the dial, that is our bottom blood pressure number, or what we call the diastolic. So top number is called the systolic. The bottom number is the diastolic. Now, these actually have names, these thumps. I call them thumps or thunks. They have a name. They're called Korotkov sounds. I think it's a whole lot easier to say thunks. Okay, but they do have a name, Korotkov sounds. So to recap, cuff on, inflate to between 160 and 180, deflate smoothly. Listen for the first thunk. Where is the needle? That's your top number. Listen for the last clear thunk. Where is the needle? That's your bottom number. And then deflate to 0. Now, you guys are all going to mess that up because you're going to get so excited that you heard the thumps and you're going to leave that needle somewhere in here. And remember, this is still squeezing the arm and the arm will reach out and smack you eventually. So don't get excited until you get to 0. Okay. All right. So when the last thunk happens, where the needle is, that is your bottom number. So for this demonstration, our first thunk was heard at 118 right here. Our last thunk was heard was set at 78 right here. Our blood pressure is 118 over 78. Good? We're going to keep deflating until our needle reaches 0, and now we can remove the cuff and record our readings. So the number where we hear the first thunk is our top number. In this case, 108. The last thunk we hear is our bottom number, in this case, 78. And that makes our blood pressure 108 over 78. So now we need to learn how to read the dial. Everybody good with where I'm at so far? Did I lose anyone yet? Okay. Do you have an understanding of what's happening inside the body? General idea. Okay. All right. When I learned blood pressure, they didn't teach any of this. They just threw us a cuff and a stethoscope and said, okay, top number is the first thunk, bottom number is the last thunk. That was it. That was all the instruction we got. We had no idea what was happening in the body. And what are these thunks? What are we doing? I don't know. And it took me forever to get this. I mean, I was a nurse, like a licensed nurse for a long time before somebody took me aside and showed me this. So I give this information to you because I know I was missing it, and it gave me a better understanding of what I was doing when I understood it. And that's why I'm giving you this information. It's not necessarily that it's going to be on the test, but I think it's important that you know what you're listening for. It helps put all the pieces together. Okay. So when you're looking at a dial, we've got a 0, goes all the way up to 340. Please don't go all the way up to 340. We stop somewhere between 160 and 180. So when you're looking at this, it's only going to give us numbers for in 20s. So we have 20, 40, 60, 80, 100, and so on. The big lines in between are your 10s. So if this is 80, that makes that 90, 100, 110, 120, 130, 140, 150, 160. The little teeny tiny marks are 2s. These little guys are 2s. So if that's a number for 140, we know because it gives it to us. 142, 44, 46, 48, and there's our 150. So those are 2s. Good? There are no lines here for odd numbers. No lines for odd numbers. So if you come up to me and you tell me that you got a blood pressure of 117 over 59, I know you're guessing. Because there isn't a human on the planet that is that able. Now, you got to remember what's happening here, right? Our hand is controlling the inflation and deflation. Our eyes are watching that needle, and that needle never stops. Remember I said that? The needle never stops. It's always moving. And our ears have to pick up a sound. When your ears hear a sound, it tells the brain we heard the sound. The brain tells the eyes, where is the needle? The eyes say, here is the needle, and the brain has to figure out what number that is, and the needle is still moving. This gap right here is not enough for you to do all of that and give an odd number. So when you tell an old nurse an odd number blood pressure, they know you're guessing. You don't want to defend that. Stick to even numbers. Now, machines can do this. A machine can give you 157 over 69. I mean, a machine can do that because they're way more precise than we are. Okay? But humans can't. Good? Okay? So even numbers only, please. So we're going to inflate to 160 to 180, deflate slowly. Listen for the first thunk, which is our top number. The last thunk is our bottom number. Deflate to 0 and document. That's all a blood pressure is. It is not that hard. But there's a lot of pieces to this, a lot of things you have to do. And that's where the practice is going to come in. So in your skills book, on page 57, you will see a gray box of practice questions. Do you guys see that? All right, if we look at number 8, you can see the little picture off to the side. I know they're hard to read. I get it. But can you guys tell me about what the blood pressure is? So 130 over 90. Is that a normal blood pressure? So in order to know that, we have to go over what normal is. So if you look in the first column on that same page, the first paragraph there, you'll see that a normal systolic or top number is between 100 and 119. 100 to 119. Now, about 7 years ago, they changed this and gave about 40 million people high blood pressure overnight because we used to be normal and now we're not. So 100 to 119 is normal for the top. 60 to 79 is normal for the bottom or diastolic. So 130 over 90, is that normal? What do we do with not normal? Report it to the nurse. So let's go down to 10. What is the blood pressure? I know this one's really hard to read, but what is the blood pressure there?
82 or 84.
Yeah, see, this one's a little bit harder, right?
64, yeah, 64. Oh, wait, 62? Yeah.
Okay, so let's look at the top number there. When you're looking at that, it is 4 ticks up from the 100. So if we look at, let me go back here. If you look here, so this is 100, 102, 104, 106, 108. So our top number is 108. 8. The bottom number is 1 tick above 60. So if this is 60, 1 tick above that would be 60, 62. So 108 over 62. Is that normal? Oh, we found a normal one. Yay.
I think the confusion is that it's missing the line there. It's only got 4 of the, do you see what I mean? See if it had that line.
Yeah, the line is, I'm sorry, the line is kind of pointing to
So
it.
that's why I think they're confused.
Yeah.
64 instead of the 62. You should see that first line for 62.
Yeah, the line, the indicator line is covering the gauge line. Yeah, that's a good point. Okay, so 108 over 62. And we know that's normal. Good. Any questions on that? Okay. So as CNAs, we are usually going to be taking blood pressure with an automated cuff. Most places have us using automated cuffs, primarily because they don't trust you. So they have us use automated cuffs. And as long as you know how to take a manual blood pressure, the automated cuff goes to the same position. Everything is the same. Good? Questions? But if we get an abnormal reading with an automated cuff, we should always double check it manually. So if I put an automated cuff on somebody and I get 146 over 92, I shouldn't trust the machine. Maybe the machine fell down and got knocked out of calibration. Maybe the batteries are going bad in the machine. I don't know what's happening here. It might be a patient problem. Patient's blood pressure might be 146 over 92, maybe. But I don't know for sure unless I check it myself. So automated cuffs can be useful. They can cut down on time and effort. But if we get an abnormal reading, what do we need to do? We'll check it manually. That could be a written question on the state exam. Okay. So your answer choices would be, you're taking a patient's blood pressure, you get 146 over 92 with an automated cuff. What is your next action? A, double check it manually. B, report it to the nurse. C, put the head of the bed down. Or D, take it again on the other arm. What do you guys think?
It's A.
Yeah.
But people would put B because you're supposed to tell the nurse.
Right.
something's
So
not
wasn't
normal.
that confusing, right? But when you go to the nurse and you say, hey, blood pressure is 146 over 92, they're going to ask, did you check it manually? Because they don't trust the machines. Okay. Good. So that's one of those situations where tell the nurse isn't the right answer. Okay. Good. So we'll inflate up to somewhere between 160 and 180. It's going to be quiet. And then you're going to hear your first thump. So let me explain how this happens. So this is what messes everybody up when they're taking a blood pressure, especially when you're new. You inflate up to somewhere between 160 and 180, and you deflate, and it's quiet. And it's quiet, and it's quiet, and nothing's happening, and it's still quiet, and it's still quiet, and you start to doubt yourself. Oh my gosh, I'm not hearing anything. There must be something wrong. Oh my gosh, oh my gosh, oh my gosh. Well, it just means you haven't got to the point where the thumps have started yet. Don't let your brain talk you out of this. Because remember, 100 to 119 is considered normal. So you might not hear a thump until you're way down here, and there's a whole lot of quiet in there. So be careful not to give up on this before the blood pressure shows up. Now, the bottom number, that's trickier. It's tricky. The reason is we don't care about the ones in the middle. Don't care at all. They mean nothing to us. But that last thump doesn't say, get ready, get set, I'm coming, ta-da. It doesn't do that. It just goes thump, 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 thump. Oh, where was that last thump? You won't know it's the last one until there are no more. So you have to pay attention to each one of those because it could be the last one. You won't know unless something else comes along. Does that make sense? So it's really that bottom number can be really tricky, especially if you were a dreamer. Okay. My dreamers, you have trouble on, you usually have trouble on the top number. My dreamers, because when it's quiet, your brain just goes out and picks daisies, right? You get up to 180, you come down, and it's quiet, it's quiet, it's quiet. Oh, I'm hungry. I wonder thump, what's for thump lunch? Thump. Thump, taco, thump, bell, thump. Oh, crap, thumps. What happened? So if you're my dreamers, you're going to have a hard time on the top number. My dancers, my rhythm people, you're going to have a problem on the bottom one. And the reason is because if you're my dancers, my rhythm people, you get into a rhythm, right? You start to anticipate the next beat. And we're a music-oriented society, so we are all into rhythm, right? If you filled in that next beat, you're going to have a hard time because you're not going to be sure, oh, wait, was it a thump or did I just imagine a thump? So even though this sounds simple, we inflate, we deflate, we listen for the first, we listen for the last. There are some pitfalls here that you need to be aware of. Okay. Make sense? Good? All right. So we talked about blood pressure cuffs, but that's not all we need here. We also need a stethoscope. Now, there is a right and wrong way to use a stethoscope, and we're going to get into that now. Everybody puts them in the wrong way. I don't know why. All right, so when we're dealing with a stethoscope, I'm going to start down here with the diaphragm, this part, the microphone part. Now, if you have one that looks like this, double tube, I think I only have one of you. Okay. So if you have one that looks like this, down here, mine is a double tube. Down here, you'll see one side is flat and the other side is rounded. You see that on yours? Okay. I'm going to just be aware of that. Okay. We'll come back to that in a minute. The rest of you, you've got single tube stethoscopes. So let me borrow this for a second. Okay. So my people with the single tube stethoscopes like this, there will be a dot on most of them. See if you can find your dot. You guys see a dot? All right. So let me explain what this is. This is a microphone, but both sides are not active at one time. Only one side is on. This whole thing turns. The whole thing turns. You guys see that? All right. We're listening for a wave of blood hitting the top of an artery buried under fat, muscle, and tissue. Not a big sound. We need a big microphone. We're going to use the large diaphragm. The dot is the on side. So you want to make sure your large diaphragm is facing the same direction as the dot. If not, just flip it all the way around. Okay. So you should have a dot on your flat side. Do you have a dot? Or is it just flat? Okay, flat is the dot. All right, good? Make sense? All right, so we have some single tube stethoscopes. We have some double tube stethoscopes. If both sides are flat, they're called diaphragms. If you've got one like this, like what I have here, this is a bell. A bell. CNAs don't use bells. We don't care. Don't need it. CNAs are going to be focused on the large diaphragm. All right, so when you're looking at the end of the stethoscope, you have a dot. This is an acoustic hole. It allows sound to transmit. You also have one on the other side, but you can't see it because you've got that disc on top. The disc is going to radiate that sound out. So this is more focused sounds. These are more diffuse sounds. That's why we want the larger diaphragm. So we want our large diaphragm facing the same direction as our dot. So you just flip the whole thing around if your large diaphragm is not facing the same direction as your dot. Now let's get to the important part of the stethoscope, the ear tips. So just as an experiment, without knowing any different, why don't you guys put your stethoscopes in your ears? Okay. When I point at you, I want you to just hold your hand up. Hold your hand up, hold your hand up, hold your hand up, and hold your hand up. And hold your hand up. And you too. Okay. If I had you hold your hand up, I want you to take your stethoscope out and look at the way the ear tips are pointing. Oh, yours was okay. It just looked funny. All right. When you put these in, the natural inclination is to put them in backwards. Over half the class did. That is the natural inclination, but that is not the right way to put your stethoscope in. And I'm going to prove it to you. So, earpieces are going to funnel this small sound, wave of blood hitting top of an artery. Small sound. It's got to funnel it to your eardrum. And adult eardrums are not backward facing. They're forward facing. So when we put these stethoscopes in, we've got to do it in such a way as our ear tips face forward. So we're funneling that sound directly to our eardrums and not to the ear canal. If we put them in this way, the ear canal is going to block it. Okay, so I want you to have your ear tips facing forward. Put them in your ears and then tap your diaphragm ever so slightly. Let me help you. Yours need to be adjusted. Some do. There we go. Let me see yours too. Nope, not towards you. Away from you. Okay, can you hear that when you touch the diaphragm? Can you hear it? You hear it? All right, take it out. Put them in backwards. And try it again.
Huh. That's crazy, man.
Okay, take it out. Put it in the right way. And try it one last time. If you have your stethoscope in the wrong way, you're not going to hear these small sounds. Okay? Does that make sense? Now, every time you watch a medical drama, you can point to the screen and laugh. They got it all wrong. When you go to a doctor's office and a medical assistant is taking your blood pressure, pay attention to how they're putting the stethoscope in. And if they tell you that you've got a blood pressure that's different from what you're expecting, it's probably user error, not your blood pressure. Okay, good. Kind of crazy, huh? All right, so if your earpieces are already slightly curved, they're set up for you. I went around and fixed the ones that are flat. So you guys are good. You just hold them and turn them. The ones that are pre-set up, they're already cemented in place. You can't turn yours. All right, so this is how it should look. Facing forward. Good? Any questions? Putting ear tips in the wrong way is a common error. It'll result in an inaccurate blood pressure reading because you're not going to hear the thumps. So we're going to inflate to 160 to 180, deflate, make sure our earpieces are in properly. Our stethoscope is in place. We're going to listen for the first thump and the last clear thump, deflate to 0, and that is our blood pressure. But let's talk about the cuff. When you put the cuff on the arm, on the patient's arm, it should end about an inch above the fold of the elbow. If you've got it way down here, it's too low. It needs to end about an inch above because we need a clear spot to put our stethoscope. We don't want our stethoscope underneath the cuff. We want it out in the open. If I've got a microphone here, you'll hear me. It's clear. If I do this to that microphone, what happens to the sound? It muffles it, it flattens it, or deadens the sound. When you put your stethoscope, which is a microphone, underneath the cuff, you are flattening that sound, which is going to make it way harder to hear. So your cuff should end about an inch above the elbow. So you've got a nice clear place to put that stethoscope. The cuff should be snug on the arm. It shouldn't be able to slide down by itself. If it's too loose, tighten it up, because now you're having to inject more air in it. And the air is what gives us our reading. So you need it snug. Your patient arm needs to be supported, not hanging out in midair. Remember we talked about that with pulse? It needs to be supported on a table, and the patient's feet need to be flat on the floor, not crossed. Good? Any questions on that? One more thing. When you're taking a blood pressure, pay attention to the care plan, because some care plans are going to say no BP left arm, or BP left arm only, or something like that. When it says that, pay attention, because there are some conditions where we take lymph nodes out of a patient. There's a lot of different reasons where we might take lymph nodes, but breast cancer is probably the number one reason. If we took lymph nodes, you don't want to take a blood pressure on that arm, because what can happen is the arm can actually swell up like a sausage and it won't ever go down. Ever. Never. We don't want to do that to our patients. So if it says no BP left arm, pay attention. There's a couple of other reasons. If the patient just had surgery, we don't want to take blood pressure on that arm. If the patient's had a stroke and one side was affected, we don't want to use that arm. If the patient has dialysis treatments and they have a graft or a fistula, we don't want to use that arm. So there's a lot of reasons why we would want to prefer one arm over another. Pay attention to your care plan. If we have a choice, if the patient goes, I don't care, whichever one, always go with the left. There is a blood pressure difference left to right. And it has to do with the size of the blood vessels. Size of the blood vessel coming off the left side is larger than the right. So if you have a choice, left is best. If you don't have a choice, then follow your care plan. Good? Questions on this? All right. So you can do the rest of these questions yourself. I'm going to give you 10 minutes to practice. That way, hopefully, you can each take one blood pressure on somebody. But let's go over homework real quick first before we get there. Tonight, you've got Chapter 4 test. I want to talk to you 1 minute about this. Chapter 4 is needlessly complex. I don't like it. You have to learn about body systems, yes. Because you have to understand that our body is made up of different systems and they all work together to keep us sunny side up. And if something happens in one body system, others are probably going to be affected. Okay. But Chapter 4 in your yellow book goes into a lot of detail that you just don't really need. What I do want you to pay attention to are the normal changes of aging. Now, we went over one of these today. Remember, we talked about that layer of fat going away and how that affects our aging population. Well, most of our patients are going to be aging population. So we need to know the normal changes of aging for every body system. Okay. But don't get too deep in what organs are in which body system. And you don't need to know that a stroke is a disorder of the circulatory system and the nervous system effects. You don't need to know all that. Okay. Good. We're also going to review this at the beginning of the class on Wednesday. So do the reading so you can kind of keep up with Wednesday. But because it is important, and I don't think that the book does a great job at it, we will review that one in class on Wednesday. I'm going to go ahead and hand out your review sheets while you guys are practicing. Remember, you have wrap-up emails. You've got today's class that you can review. And if you haven't enrolled in the online program or haven't accessed it, remember that you are enrolled in that online program as well. Okay? All right. So for those of you who are joining us live, we're going to go ahead and sign off. So until Wednesday, happy caregiving. Bye.